Good evening, it's Dr. John Bennett, televising from dark Miami. Today we have another conference in the Conference of Pediatric Neurosurgery, a collaboration between Neurosurgical TV and the Deepak Gupta of the Department of Neurosurgery of the AIMS hospitals in India, AIIMS. He's assembled a great cast of speakers, and we have another great speaker tonight. We have Alma Griselda Ramirez Reyes. She's going to be talking about cerebellar mutism. And first, let me introduce the panel. Good day, Norma. Could you introduce yourself, please?
Oh, yeah. Hello, my name is Norma. I'm a physician, general physician, and I run a medical students chapter in my country, medical students with interest in neurosurgery. That's through AANS.
Very good. Very good. Welcome, Norma. And Simon.
Hello, my name is Simon Downs. I'm a medical student and psychologist in Tokyo. Looking forward to the presentation. Thank you very much.
Okay, member of the team. I love your background. Okay, Griselda, welcome, and it's all yours.
Thank you very much. My name is Griselda Ramirez. I am a pediatric neurosurgeon working at Mexico City. It's my pleasure to be here with you, sharing my experience about the cerebellar mutism. And wow.
Yes, we can see it.
Yes? Okay. The posterior fossa syndrome is a devastating complication of surgery encountered the patients operate on 4 midline tumors in the posterior fossa. It's characterized by a profound neuropsychological disturbance, the central manifestation of which is cerebellar mutism. This was first reported in 1979 by Hirsch after a posterior fossa tumor resection. And the author of most patients show some improvement with time. Many of them don't fully recovery. The impact of posterior fossa syndrome on patients, family, and healthcare providers is considered. The cerebellum participate in language learning, mental and social function, and the mutus is considered severe coordination of the volitional motor aspects of speech. And all these disorders is observed in the patient with posterior fossa syndrome. The cerebellar anatomy and function is very important for understand the several disorders. The anatomical location in left lobe have function in visual, spatial, executive functions. The right lobe is implicated in language. The anterior lobe have implication for truncal ataxia and hypotony. The posterior lobe is have relation with appendicular ataxia, hypotony, tremor, and the vermis is related with emotions. The cerebellar involvement in reading ability development is really important in children from birth to 12 years. We performance sensory-motor networks, language and learning networks, and we performance sensory-motor cognitive integration. Also, the cerebellum plays a role in high-order behaviors like neuropsychiatric and genetic disorders like attention deficit, autism, developmental dyslexia, Fragile X syndrome, and Down syndrome, and schizophrenia. And the most important for neurosurgeons is the posterior fossa tumors. This is really common in children, principally the medulloblastoma, pilocytic astrocytoma, and in some cases ependymomas. The posterior fossa syndrome is important understand these cerebellar motifs, also known as posterior fossa syndrome, is a relatively common complication of posterior fossa surgery for primary brain tumors in children. Many children with cerebellar motifs experience long-term adverse neurological, cognitive, and psychological sequelae and require extensive interdisciplinary support. This graphic was performed for Dr. Gudrun Adbottir in Iceland for describe posterior fossa syndrome. This is really complex syndrome, include neuropsychological, neurological, and language speech. And the most important and severe is cerebellar motifs. The studies with tractography and functional MRI have important functions for describe the pathways for language in the patients, and the cerebellar thalamus-cerebral connections impact on working memory. The principal pathways is the interrubral thalamocortical pathway and the interrubral olivary pathway. These studies describe dentato-thalamocortical tract. The proximal components, dentate nuclei, superior cerebellar pedunculus, and their deposition in the mesencephalic tegmentum of the efferent cerebellar pathway are often invaded by posterior fossa tumors and are prone to surgical damage from radical resection. Efferent fibers from the dentate nuclei leave the cerebellum through the superior cerebellar pedunculum, decussate in the mesencephalic tegmentum, and synapses in the ventral lateral and ventral anterior nuclei of the thalamus. The corresponding postsynaptic neurons project to widespread cortical areas, including the primary motor, premotor, and prefrontal cortex. Bilateral damage to the proximal efferent cerebellar pathway has the potential to disrupt the efferent cerebellar signals and deprive the cerebral cortex of cerebellar input in a fairly global fashion. Functional disconnection of this area may cause a complex neuropsychological disturbance, such as posterior fossa syndrome, with significant impact on various aspects of neurocognition. This is really interesting diagram about the Gillian-Muller triangle with relation to the proximal efferent cerebellar pathways, and the posterior fossa syndrome is a complex functional disturbance affecting cortical areas involved in cortical neurocognitive process, which develop remotely from the site of surgical injury through a transsynaptic reflex mechanism. Diastasis is defining as sudden inhibition of function in an area of the brain remote, but anatomically connected through transsynaptic neural pathways to the site of primary injury. This cerebellocerebral diastasis is the most common form. The hallmark features of diastasis are hypoperfusion, decreased oxygen consumption, and hypometabolism. is frequent, also is frequent in ischemic stroke. These are cases of medulloblastoma in the midline of cerebellum, and occupied all the foreventricle and compressed the brainstem. This is other studies of MRI for observed dilation and compress the brainstem and extending into the spinal conduct. Several studies are performed about the language and the cerebellum, and this interesting study with clinical symptoms and ataxic dysarthria and apraxia speech, and they performance the difference between dysarthria and apraxia of language. This is a cases of the posterior fossa tumors and approaches, and the most the televelar approach is a more safety technique for remove posterior fossa tumors in the midline of cerebellum. Several neuropsychological tests are performed for study the patient with in children's aged use subtests of the Weschler press calls, Alice's revised naming vocabulary test of the differential abilities scale, and tailor children's stories, their visual motor integration, and Gardner expressive one word. In children's aged 5 to 16 years, use subtests Weschler intelligence scale for children revised, automatic sensories, Boston naming test, sentence memory and learning, very visual motor test, and Ray Osterrich complex pygory. This is other study about the neurocognitive outcome 12 months following in cerebral syndrome in pediatric patients with medulloblastoma. And the most important function in this test was the broad attention and processing speed and cognitive absence are the more statistical significant. And the cerebral mutant suspects include for study the cognitive, affective, behavioral, language, speech, neurological, motor, and somatic. This is really important in preparative symptoms, and it's important performing these studies and postoperative symptoms in children. In the last 30 years, performance all these studies in all the world about the cerebral mutism and posterior fossa syndrome. In our hospital, in the last period of 2011 to 2015, we have 33 cases of posterior fossa tumors with age 3 to 15 years old, male 23, family 7, 3 patient deep. And the most common tumors was medulloblastoma and ependymoma, and in 3 cases low-grade astrocytoma, and 1 case of glioblastoma multiforme, and 1 case of rhabdoid teratoid tumor. This patient was studied in preparative and postoperative, and the follow-up for 12 months. They have neuropsychological disorders in 10 cases, and in the follow-up persisted in 4 cases. The irritability was common in 10 cases and persistent in 3 cases after 12 months. The cognitive was the same in 5 cases. Affective behavioral in 4 cases, and neurological motor was the most frequent disorder in 30 cases, and are better 24 after 12 months. In neurological somatic disorder, we have 22 cases preparative and only 2 cases in the follow-up. In language speech, only have 4 cases in preparative, and in post-operative increased to 6 cases, and in follow-up only have 4 cases with language and speech disorders. And cerebellar meningitis previous, we have 9 cases and are better after surgery. 3 in cerebellar after surgery, only 10 cases, and this was transitory in 3 cases. In cerebellar meningitis after 12 months in 7 cases, and long term in follow-up only 6 cases. Children with cerebellar damage are particularly at risk for long-term neuropsychological dysfunction and require key rehabilitation measures. Reducing surgery-related morbidity should be the next goal to reduce post-surgery specific deficit. And neuropsychological and logopedic rehabilitation is necessary in all cases for performance better prognosis in these patients. We invited yours to the next Congress for Pediatric Neurosurgery in Latin America the next month. Thank you very much.
Very much.
Okay. I'm sorry. I was just doing some other tasks. Thank you very much. Thank you very much, Griselda. Excellent, well illustrated, good pictures. And thank you for promoting the conference at the end of the month. Next month in pediatric neurosurgery. Okay, yes. I'll open it up and I'd like you to meet Deepak Gupta. He's the organizer of this conference. This is Griselda Ramirez-Reyes from Mexico City.
Hi, good morning.
Hello, thank you very much.
Must be late evening for you out there.
I'm sorry, Doctor, what did you say?
What's the time there in your country?
9:30 at night. It's 1 hour earlier than Miami, so it's not too bad. It's not too bad for her.
I have a question for you. These children with cerebellar mutism, how do they progress? I mean, what is the usual time when they improve after surgery?
Did you hear that, Norma? Did you hear that, Griselda?
Okay. ¿En cuánto tiempo los evaluamos?
Yeah, you said, how do these patients progress with mutism? How long do they take to improve? ¿Cuánto tiempo para mejorar?
¿Cuánto tiempo?
Para mejorar.
Okay. After the surgery, in some cases, 4 weeks to 8 months.
8 months after. Okay, I'm sorry.
What?
I'm sorry to interrupt you. You said eight months
Yes,
after the
but
surgery, that's when they start to improve?
yes, for these cases, we spend the time for 4 weeks to 8 months, and they a therapy for language, and they for language and for learning, we performance with the mental health system for help these children, and we don't use the medicines like pharmacological rheumocryptine. We don't use this. We only use the rehab rehabilitation for language.
Okay. Okay,
What percentage?
Simon or I'm sorry, Dr. Gupta, do you have another question?
What percentage of children remain with some deficits?
¿Qué porcentaje de pacientes queda con problemas? Con déficit.
Approximately
Con déficit.
40. Approximately 35 to 40%.
¿Qué porcentaje?
But many,
¿Qué
de 35 a 40%.
Okay. Okay.
Es really high.
Okay.
But many patients.
Okay, I'm sorry. I guess we got lost there in translation. Okay, Norma or Simon, do you have any comments or questions?
Yes, please. Thank you very much for your presentation. I was reading that although it's much less common in adults, that in adults after 7 to 8 weeks that they often see complete resolution. In children, do we see complete resolution? Is that possible, or are they always left with some deficit?
May I also ask, is it related to the type of tumor, or it's purely a surgical insult? The cerebellar mutism, the incidence, does it vary with medulloblastomas, ependymomas, pilocytics? Is it different in the 3 different tumors, or it is purely a surgical issue?
Okay. Okay. Okay, Norma, do you have any comments or questions?
Okay, well, it was a very nice lecture. Thank you, Dr. Griselda. And I just have a little question. Is prognosis directly related to the age of the children? I mean, younger children, do they have better prognosis? And older children may have a worse prognosis? Or are there any studies, or is it just different, or is it not?
Did you hear that, Norma? You hear that, Griselda?
The prognosis for little children is better to respect the old children's for performance, the language, the behavioral, cognitive. It's really different. And this is really important if the patient have the esquisses, cerebral is the most important factor for development, the language, cognition, learning, and neuropsychological disorders. This pathway is the most important in this patient.
Okay. Okay, muy bien. Muy bien. Okay, muchas gracias, Griselda, por tomando este tiempo. I'm sorry. Thank you very much for taking the time to give this presentation.
No, thank you very much. Thank you very much, John and Dr. Deepak Gupta for
yeah, maybe someday you'll
for
meet.
Sharing with me this space.
You know, Dr. Gupta, Griselda has been to India.
Yes, I have 3 times in India.
What part of India did you go to?
Goa, ISPN 2011.
No, I was only for traveling for tourists.
Okay. So
Okay.
you're invited to come to India anytime. We will be very happy to have you.
Yeah. Well, if you notice on her profile, she has a lot of pictures of her trip to India, mostly around New Delhi, right, Griselda?
Yes, I was in Delhi 2 years ago. For sure, Tom, this is nice place.
That was just vacation, right? Not medical.
No,
It's solamente vacation. Okay, very good.
only for
Okay, okay, we'll wrap up this conference, and we look forward to the next one. And you're all invited to stay. It'll start in about 30 minutes with Manas Panagrahi, MD, in endoscopic management of hydrocephalus. Thank you.
Thank you very
Thank
much.
Thank you. Okay, we're gonna edit this and stop it, but we have a break. We have a break for a half hour, so we can go to the cafeteria and have a coffee.
Yeah, online
Okay.
call.
Coffee or tea.
Online coffee break. Okay, Uma, there's someone on the panel. Okay, Simon, you gotta go? Okay, no problem. Yeah, it's really late. Uma, can you hear me okay? There's someone with new one on the panel. Do you know Uma?
Yeah, I can hear you. I can hear you. Yes, I do.
Oh, Uma left. Okay, Uma left.
It's just my...
Okay. Yeah, Dr. Gupta, Norma is the head of a big organization in Mexico City of students. Can you tell Dr. Gupta about your organization, Norma, of students that like neurosurgery?
Yeah, that's a medical students chapter through the AANS. So the American Association of Neurological Surgeons, they offer this medical students chapter. And we did that in our university, which is a huge university. It's actually the biggest university in Mexico. So there are about 300 or 400 students in the chapter. So it's a huge one.
Yeah. And how often do you have lectures and talks, right? Conferences? How often do you have that, Norma?
We do that monthly, but sometimes we may do 2 conferences a month. Sometimes we do 2, sometimes, but usually we do it once a month.
Yeah, Norma's in Mexico City, right?
Yeah, that's right, Mexico City.
Yeah, I'll try to get a picture of that. I was really impressed when I saw that picture of a presentation.
Oh.
It was a big crowd of students.
Yes.
It was amazing. You know the picture I'm referring to, right? Norma, you probably do, right? Okay,
Well, John.
Yes.
I think this is a very good initiative. Yesterday we had Francesca from Romania, Bucharest, and today we have Norma from Mexico. Am I correct? You are from Mexico?
Yes.
Yeah, that's right. That's right. From Mexico City. That's right, doctor.
You are kind of the new generation to the field of neurosurgery or pediatric neurosurgery, and you have a very, very important role to play. And you know, as pediatric neurosurgeons, we would like to have more and more of neurosurgeons to take it up as a subspecialty. I don't say that you stop doing adult neurosurgery, but you should take some active interest in pediatric neurosurgery, because 1/3 of the pediatric population in the world is in India and in some other parts of the world. So congratulations to you for joining us for this meeting, and I'm sure you'll be able to come up to the responsibilities which have been given to you by AANS. And if there's any way I, on behalf of Indian Society of Pediatric Neurosurgery and from India, could assist you or your student organization, please feel free to write to me, and we will ensure that all your issues are taken care of.
Thanks a lot.
Well, you know, Dr. Gupta, she could take you up on that, because her organization is big, 300 or 400 students. Maybe you or one of the associates could give a presentation to.
Yeah, that would be lovely.
And that would be great if you could have an Indian neurosurgeon give a talk to the Mexicans, 300 or 400 people.
Yeah, we will love that. Totally, we will love that.
So
an online conference for the
don't
medical
mind, I'll
students.
give her your email address, and she'll keep in touch with you.
You have your group, I mean, a group of 400 people in one common place, like Facebook group or a Mexican students group?
Yeah, we do. We have a Facebook page, And we also
Okay.
have a website, so you can go to the website, to the web page, or to the Facebook page. We have both.
Perfect. So
Yeah,
maybe
we have
John
both.
could get me connected, and then we could be in further touch with the video group in the time to come, and we'll see what we can do.
Yeah, thank you. Thanks a lot, Doctor.
Very, very good.
Okay.
Very
Take care.
good.
Thank you.
Okay. Okay. We're gonna meet back here at in about. We're gonna start a new link. Dr. Gupta and Griselda and Norma. I'll send you all a link, and we're gonna start another
Sure.
another.
So next is me after half an hour on split cord malformations.
Yeah. Well, it's
Okay.
on endoscopic management of hydrocephalus with
No,
Manas.
no. I am talking on split.
Oh, are you gonna take your spot?
Yes, I can take my slot.
Oh, you're gonna talk next?
Yeah. Did you ask somebody else?
Well, Manas Panigrahi is scheduled.
So what I can do is I can finish off my talk before 9 o'clock. I can begin even now if you want.
Okay, let's do it. Let's do it.
Okay.
Okay, let me introduce you first. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, good afternoon, good night. This is Dr. John Bennett televising from Miami. We have another in a conference of Pediatric Neurosurgery with a collaboration of Neurosurgical TV and Deepak Gupta of the Department of Neurosurgery of the Ames Hospital, AIIMS. Today, Dr. Gupta is going to give a presentation, and first let me introduce the panelists before Dr. Gupta gives his presentation. Hello, Alma. Hello, Griselda.
Hello, how are you? I'm Griselda, a pediatric neurosurgeon in Mexico City.
Welcome, Griselda.
Thank you.
Okay, Norma.
Okay. Hello, my name is Norma. I'm a general physician, and I'm the head of a medical students organization through the AANS with interest in neurosurgery, of course.
Hey, welcome, Norma. Okay, Deepak, it's all yours.
Hi, good morning, and greetings to all of you from India. And it's a very warm, pleasant good morning here in New Delhi city. The weather is quite pleasant, and I just reached my office, and so I'm very happy to have you on the panel. And let's go ahead with my talk.
Okay.
So in the next few minutes, I'll be briefly discussing about split cord malformations. As you can understand from the name, split cord basically means when the spinal cord is divided into two parts. Various classification systems are available. People used to call it diastematomyelia, diplomyelia in the earlier times. However, in 1995, Deckling Pang gave a unified classification on common embryogenesis, and subsequently, in most of the part of the world, they are classified into two different subtypes, that is type 1 or type 2 split cord malformations. The basic difference between the two types is, in type 1, we have got two dural tubes. I mean, there are two separate sacs, and the spinal cord, naturally, they are divided into two parts. So in both the types, type 1 and type 2, you have got two spinal cords. However, if we have got each spinal cord covered in its own dural sac separately, then we call it a type 1. If you have a single dural sleeve in which two hemicords are present, then you call it a type 2 split cord malformation. There are various other associated anomalies like paramedian nerve roots, myelomeningocele, centromedian vascular structures. However, they are not used for classification into type 1 and type 2 because both of these can be present in the other condition. This is how actually it looks like. You can see there is a septum which could be bony or a cartilaginous septum. This is one spinal cord in a separate dural sheath. This is one other spinal cord in a separate dural sheath. However, if you look at the type 2 split cord malformation, there is a single dural sac. Can you see? That's a single dural sac, and there is a septum in between. However, the dural sac is single. So these are one hemichord, this is another hemichord, and there is a single dural sheath. Because these are congenital malformations, and the defect lies in the embryogenesis when the baby is approximately 26 to 28 weeks. In fact, before that, it usually begins around 7 to 8 weeks of period of gestation. So because the problem is with the embryogenesis in this patients, they usually have got associated congenital malformations. Almost 50% of these people, they have got hydromyelia. 30% of the cases, the spinal cord is asymmetric. By this I mean one hemichord is large and another hemichord is hypoplastic or smaller as compared to the counterpart. Usually they are associated with thickened phylum in almost, I would say, more than 90 to 100%, almost all cases. They also have got high incidence of association of phylum lipomas and associated cord lipomas. We talk about the spine, they have got bony or a fibrocartilaginous septum or a spur in 50 to 100% of the cases. And in fact, this is the thing which is responsible for causing tethering, and that is why these patients require early surgery to prevent any deterioration. They have got anomalies of the vertebrae, they have got scoliosis, and of course some of these patients, they have got spina bifida volta where there are no overt skin manifestations. A lot of these children, they have got skin anomalies. In fact, when these children go to pediatricians, private practitioners, if they see this hypertrichosis or abnormal tuft of hair at the back of a child, it makes you go suspicious. Yeah, this is a child, excuse me, who could be having associated underlying split cord malformation. So almost 46% of the children, they have got hypertrichosis, and 20% of the children, they have got lipomas, dimples, and dermal sinuses. So this is how they actually look like. If a child comes to you with the abnormal tuft of hair at the back, yes, you should suspect there is an associated underlying anomaly in the spinal cord or the spine. You see this small dimple or a dermal sinus, you see the abnormal tuft of hair. You can see this the cutaneous hemangiomas or the skin tags and skin lipomas. So whenever you have a child with something abnormal at the back, the pediatrician or a neurologist or a physician who is seeing these babies, they should be counseled to send these patients to a neurosurgeon at the earliest possible for timely intervention and evaluation. Coming to the clinical presentation, well, at birth they can have skin anomalies, as I just told you. They can have orthopedic deformities like club foot or CTEVs, or even hip deformities. They can have neurological deficits, the severity of which varies from children to children. If you talk about the older presentation, when a child is slightly older, let's say 3 or 4 years of age, in addition to this skin, orthopedic and neurological deficits which may be present since birth, some of these children, they actually present with sphincter disorders. Sphincter disorder, they will have difficulty in controlling micturition. There will be episodes of bedwetting or inability to hold urine. When the child grows up, in addition to above all symptoms, the skin anomalies, the orthopedic deformities, neurological deficits, sphincter disorders, they will have scoliosis because the vertebra are abnormal. Some of these vertebra are hemivertebra or hypoplastic vertebra. So when the child grows in the adolescent phase, the spine gets deformed, and almost 50 to 60% of these children, they manifest with scoliosis. And in fact, some of the cases, they present you with scoliosis to an orthopedic surgeon. They evaluate the MRI and they find that these children, they have got split cord malformation, and then they refer it to the neurosurgeon for detethering of the cord, release of the fibrous band, or knocking off the bony spur, so that they can do the corrective surgery. And it must be very important to remember that all these patients at any age, they can present with pain. Young patients, they can present with pain and manifest with excessive crying. The children will have excessive crying, or they may directly complain of pain at the back or while walking, and same is true for the adolescent also. The presentation can be delayed to as old as 40 years, 60 years of age. We have got cases with congenital spinal dysrhythm presented to us at the age of more than 40 years of age also. But these are anecdotal and very, very few cases. If you talk about the diagnosis, well, the diagnosis is pretty straightforward. If you do a plain X-ray, you can see the patient may have scoliosis. There could be vertebral anomalies. There could be spina bifida or lack of element of the posterior element on the plain X-rays. Ultrasonography is feasible when the child is less than 3 months of age, but it is usually not so commonly used, I would say. You need expertise to do the ultrasonography. The MRI is I would say, the investigation of choice in the diagnosis and management of these patients. And of course, some of the cases you can do a low dose CT or a 3D scanner evaluation to evaluate and to characterize the fibrous or the bony spur further. In the prenatal period, ultrasonography, of course, remains to be the investigation of choice, and competent radiologists can actually diagnose this condition when in utero itself. The MRI or the fetal MRI is very good and very sensitive after 30 weeks of gestations, and people have also tried doing a CT or a 3D CT after 38 period of gestation, but this is not something very commonly used. Now, what is the natural outcome in spinal dysaphisms or split cord malformations? Well, we all know they have got congenital deficits. We all know that neurological spontaneous aggravations, they do occur in these children. However, we often ignore the incidence of neurological aggravations and what is the mechanism of neurological aggravation. That is something which is often ignored. The hypothesis commonly given for neurological deficit is that a lot of these children, they have got associated myelodysplasias. There is a growth related tethering. There is no age correlation, no site correlation has been shown, but with the growth of the child, there is a tethering which increases. There is a local injury during neck or the spine flexion by the bony spur and the fibrotic bands. So all these things have been found to be responsible for causing neurological aggravations. So congenital deficits, as I mentioned, again, if you see on this side, the right hemichord is smaller, the left hemichord is bigger. So naturally, these patients will have right monoparesis or ipsilateral monoparesis and ipsilateral hypertrophic limbs. So some of these children, they're actually born with these deficits. And it is very important to study the patient's MRI before itself, or the CT myelo or the CT low dose itself, to be able to prognosticate to the patient's family. Look, your baby is already having a thinned out hyperplastic cord to begin with right from birth, and this is unlikely to improve. The reason of surgery in these people, in these patients of split cord malformation, is prevention of further neurological deficits or stopping or halting the progression of the neurological deficits. It is not for reversal of the deficits. To talk about the management, well, people always say the Medicine in 1969, he said that yes, the management is purely prophylactic rather than curative, and one must evaluate the results in terms of halting or slowing progressive loss of function, as what I said just now, or preventing its appearance. In fact, McClone and Decklin-Pang, they feel that in type 2 patients which are asymptomatic, you may not offer any surgery because there is no bony spur in these patients, and only when they have some symptoms you can offer surgery. But however, the opinion remains divided. People who are involved in athletic activities and very vigorous extensive exercises, they run a risk of deteriorations, and some of these children or adults, they may not have any deficits, but they may have worsening on the urodynamic evaluation for the bladder function, and in such cases some surgeons, including me, we offer surgery to these patients. However, there is no doubt that all symptomatic type 1 or type 2 patients and even asymptomatic type 1 patients should be offered surgery. There is a consensus all over the world that these are the patients should be operated. And as I mentioned before, prior to any orthopedic spinal deformity correction, one should take care of the type 1 split cord or type 2 split cord malformations for sure. Otherwise, there is a very high risk of deterioration when the orthopedic surgeon corrects the spine. So people have done and shown very contradictory results with the prophylactic management. Way back in 1974, people found that Gutkelche found that in 10 of the non-operated patients, they remained stable, and only 8 required surgery. And in 12 of the operated patients, none of them deteriorated. However, in the Hood in 1980 found that in 6 non-operated patients, no one deteriorated. So the outcome of surgery or no surgery or conservative management or surgical management was almost the same. So people have shown very contradictory results, and that is a part and parcel of any observational study being carried out. So the surgical technique I'll be describing a bit later. By and large, when a patient's family or a parents come to us, this is how we commonly explain that these are the symptoms which are likely to improve in your patient. There is a likelihood that more than 75 to 90% of the patients will improve in pain. Only 44 to 55% of the patient will improve in the bladder functions, and the deficits may improve in 30 to 60% of the cases. The orthopedic deformity is unlikely to improve unless and until it is addressed by surgical intervention for the scoli or the kyphoscoliosis correction by the orthopedic clinic. It is very important to tell to the patient, because when the patient's family come to you, their first question is, what are the symptoms which are likely to improve and why I should subject my child to surgery. And these are the children of different types of meningomyelocele presenting. In fact, these young children, because the MRI is often not done, I always go one level up to see if there is an underlying split cord malformation. And there's so many cases, at least 2 to 3 cases per year I come across, wherein along with the meningomyelocele, I do have associated split cord malformation in these children, which needs to be addressed. Now, the goal of surgery in split cord malformation is basically release of the tethered hemicords by eliminating the bony spurs. The dural sleeves should be made into one, preferably the release of fibrocepta or any fibroneurovascular bands. The type 1 cases where there is a bony spur, they are technically difficult or challenging, I would say, and they do have a slightly higher surgical morbidity as compared to the type 2 cases. In type 1 cases, if there is an oblique bony septum, then the spinal cords are two spinal cords are obliquely placed, and one hemicord is smaller and the larger hemicord is there, which is there facing you. And in those cases, there is always a very high risk of deterioration if the surgeon has not done careful pre-operative planning as to what will be the exact location of the second hemicord. So this is a pictorial diagram. In fact, it's the diagram by me, and it got published in JNS Neurosurgery way back in 2005, I suppose. And this is how it looks like. The type 1, this is the 1, this is 2, and this is the septum. You can see out here, and these are the 2 hemicords. You can see this is one hemicord, this is another hemicord. This I have already talked about, and this was my work published in Journal of Neurosurgery Pediatrics in 2005. Wherein I studied over 250 cases of split cord malformations over 8 years, and you can imagine what percentage of spinal dysplasia we see in our clinical. We have a huge population of children coming to us with various spinal dysplasia, and in fact ours is one of the reference center for treatment of these conditions. So the lumbar location was the most commonly seen of the split cord malformation, and the type 1 was noted in over 156 cases. Almost 15% of the patients were asymptomatic. Rest 85% of the patients, they had some symptoms. It just goes on to say that over 80 to 85% of these children, they will have some deficits. Kyphoscoliosis and scoliosis were present in over 40% of the cases with type 1 split cord malformations in my 250 cases which we analyzed. We further subclassified type 1 split cord malformations into 4 different subtypes. This is the bony septum in the center, and you can see this is one hemicord, this is another hemicord. The spinal cord usually bifurcates, and then it usually either reunites or it remains single as 2 separate conus or 2 separate phylum lower down. But by and large, it usually unites below the bony septum. Now, in type 1, what we saw that the location of the bony septum and the division of the spinal cord varied in different patients. Some of the patients, it was in the center, which we call type 1A, like this. This is the septum, this is the bony spur, and this is the right hemicord, this is the left hemicord. And you can see they are obliquely placed. This hemicord is lower down, it is more posterior, and this one is more anterior, which faces the surgeon when you open the dural sheath. In type 1B, the bony spur is at the upper end of the bifurcation, and so there's a lot of cord below, and so it is always technically more easier to dissect out here and go to this area the last. In type 1C, the bony spur is at the lower end, the bifurcation is higher up, and so your surgical strategy is planned accordingly. In type 1D, the bony spur is tightly straddling the bifurcation, you can see. It is tightly straddling the bifurcation. And these are the cases which are more commonly seen in very young age group, especially the neonates. And these are the cases where the risk of neurological deterioration is very, very high, because when you are drilling or nibbling or taking care of this bony septum to release it, there is always some amount of handling of the spinal cord on either side, and the surgeon needs to be very, very careful in avoiding any handling of the two hemichords. You can see very carefully the right hemichord, the left hemichord, one dual sheath, another dual sheath, and this is the bony septum, which is black or the hypointense on the MRI. Now, the most important thing to be noticed is that, can you see this white dot out here? So, this white dot, it reflects that there is some amount of syringomyelia or a cavitation inside the spinal cord. This usually comes with continuous tethering or ischemia of the spinal cord. So, these are the children who have got very high incidence of deficit and a likelihood of worsening after the surgery. So this is right hemichord with a syringomyelia. Left hemichord looks smaller, but there is no syrinx in that. And they have got associated anomalies. You can see there is a big syrinx out here on the T1 and on the T2 images, and that's the level of the spur. Coming to the outcome, in 250 cases which we operated, we had transient neurological deterioration in the motor symptoms in 7% of the cases. However, we had improvement in over 40% of the cases. Sensory improvement was noted in 60% of the cases, and autonomic involvement improvement was noted in 27% of the cases. This I'll skip. This is a 1-year-old girl with a type 1D split cord malformation, and she also had a right hemichord lipoma and a low-lying. You can see the cord is ending at the level of L3, L4 level. So this is a low-lying tethered cord, and this child also had got associated rib anomalies, and some laminar and the vertebral anomalies are also there in this child. This is how it looks like after the surgery. This is another child, and you can see that there are limb anomalies and there is some kyphosis being present in the child. Another child is a type 1 split cord malformation. This is how it looks like intraoperatively after the removal of the spur, a type 1D case. This is actually a pictorial representation of how the type 2 looks like. You can see intraoperatively there are two hemichords. There was no bony septum, just a fibrous septum, and there is a single dual sheath. This is the pre-operative planning, and these are a few cases of long segment type 1 split, and this is some of the cases. If you don't excise the spur completely, there is a regrowth of the septal spur, so we need to excise up to the vertebral body level the bony spur. Post-operative MRI is recommended. I do it at the end of 6 months in all my cases to assess the thoroughness of removal of the septum or the tethering elements, and to see if any hemichords are adherent to the stump, if resected stump, and to detect any post-operative ventral tethering. And I also want to see the response of the residual terminal syrinx, whether it has increased or decreased in size after my surgical intervention. These are some of the cases. You can see a large bony spur which is going. You can see the bony spur here, and these are the two hemichords. The right hemichord is so small in size that it is barely visible. This is another patient. This is a CT scan. You can see on a CT scan, actually you can plan out and make out what is the direction of the spur, whether it is oblique. Most of the cases it is oblique and dorsally directed, ascending up. Secondly, by looking at the various sequential cuts, you can also make out what is the subtype of split cord, whether it's a type 1 A, B, C, and D. And the surgeon actually can plan out his surgery before itself to minimize or to avoid any deficits in these children. This is how this was the dermal sinus there. So naturally you have to go at least 2 level up and 2 level down to be able to do a wide dissection and to be able to reach. So this is a child. The challenge in these children, you can see, is most of these children, they usually do not have major deficits. So it becomes more of a surgical challenge to the patient. So the parents would like to see their child in a very, very healthy state even after the surgery. This is a 2.5-year-old girl who had a type 1 split cord malformation, and this is how it looked like on her back. And this is how she was after the surgery. She was moving her limbs well, and there was no deficits. So the aim of surgery in these cases is release of the tethering by median mesenchymal septum to hemichord or the other lesions. So all this has to be released. In the preoperative neuroimaging, you have to look at the CT scan very carefully where the bony septum is actually beginning and the direction of the bony septum. So we have to really carefully study the preoperative CT, because when you are doing the dissection of the muscles of the lamina, again we need to be very careful if there is a spinal dysaphism locally, and so we should not be entering into the spinal cord by mistake by our monopolar cautery or a bipolar cautery in case somebody is using it. You can see there is an oblique septum which is going up. This is in fact one of the commonest direction of the septum, bony septum, which we see in our practice. And the most important thing is that you have to screen the entire neuroaxis from the top to the bottom. You can see there is a tiny white dot out here, that's a syrinx out here, and some of these patients, especially if they have got meningomyelinosis, they may have got Chiari malformations, and higher up they could be having hydrocephalus also. You can see this is another child. There is a bony septum out here. This is one hemichord. This is another hemichord. And if you see very carefully, there is a white dot that reflects there is a syrinx inside the left hemichord. So all these things has to be pre-operatively studied, and this is where the phylum is ending. And so naturally, if we collaborate it further, it is ending at the level of L3. So that means it is a low-lying tethered cord with the left syrinx and split cord malformation type 2. So these are the things a surgeon should be knowing before operating in this patient. As most of these children are actually intact, there always remains a surgical challenge to the surgeon because of the expectations of the parents that the child should be absolutely fine, walking without any deficits. And we all know that there is some risk of operating in the split cord malformation type 1 patients. So nowadays it is advised, and we routinely practice intraoperative neurophysiological monitoring in these children. So all the roots, the lumbar and the sacral roots, the pudendal roots, the sphincters, they are constantly monitored at the time of cord handling or release of the bony elements and the detethering to pick up any deterioration if so ever. And this is really helpful. This is the same child position after the surgery. You can see all the leads have been, the anal sphincters are in place, and all the lower abdominals, the rectus and the lower limb muscles are being continuously monitored. The anesthetists, of course, need to give the anesthesia drugs to maintain MSE of 0.2 to 1.0, and usually if nitrous and sevoflurane combination, which is commonly given by the anesthetists. The IV relaxants are usually not given to the kids. These are the stack of recordings which you see. The red one is the baseline, the green is what we get during the surgery, the MEP recordings, and these are the stack recordings. So the neurophysiologist who is sitting with you while you are operating does a series of direct and MEP stimulation, the motor evoked potential, and he can guide you during the surgery when you are doing the detethering and removal of the bony spur. This is a girl child, you can see, and so this is how the position. I usually place my child in slightly triangular position, full prone, so there is no CSF, there is no CSF drainage, and I keep the abdomen completely free. And I do check for the electrophysiological electrodes very carefully and do a baseline recording before I begin my surgery. And the preparation remains standard as in all cases, and some amount of local anesthetic is given to decrease the pain post-operatively, and also for some decreasing the bleeding. And so the level needs to be checked. All these children are catheterized before the surgery. So the skin incision is usually 2 level up and down the median septum. The localization of the septum is always extradural first. So we should see the adjacent dural arch anatomy first, and because in some of the cases the bony septum which is there, it may be fused to the overlying bony arch. This is a video of a child. I'll just show you the surgical steps on. So this is a 1-year-old female with a tuft of hair over the lower back, and it was intact. And this child I operated last year in November, and this child I showed the video. And this is the operative body of the child. You can see there is a bony septum. This is the syrinx, so you can see in the proximal cord in the same child. And this is how it looks like. The MRI, you can see there is a big complete bony spur which is dividing the cord into 2 parts. and this is how the bony spur looks like. It is basically going to the right side, and this is the positioning of the child, the anal sphincters, the lower limb muscles, the lumbosacral roots, they are all monitored. And you can see once you are done with the dissection, the skin, subcutaneous tissue, and the fat, that's the bony lamina, and that's the abnormal mass of the bone, which is actually connected to the underlying bony spur. So you have to define the normal dura at the proximal or at the distal end, and very slowly you need to use your rongeurs or your drills to define the plane all around this normal dura. It's a very tedious, time-consuming surgery, I would say, and the surgeon should spend good amount of time in defining the dural sac in its totality all around the spur, and that's the lower end. You can see, and you can see this bluish thing. You can see that's the dural sac. I have not opened the spinal cord as yet, so I did the dissection on the upper end, and now I'm doing it on the lower end, and now I'm doing it on both the sides. You see, that's a dural sac on this side. And all this surgery is done under microscopic assistance with a magnification of 4 to 6 times to see the structures carefully, and to prevent any inadvertent opening of the dura or damage to the underlying cord. You can see now this is the bony spur in the center. I've opened the dura on both the sides. I don't see the hemichord on my side, which is the left side, as yet, because this is hidden behind. And you can see this hole is the septum along with some lipomatous tissue in the center, and very soon we will see the spinal cord. So this bone is actually drilled in between in the center, and you can see this is the one hemichord. Can you see this is the one hemichord on the right side, which is opposite me, and inside I have poured the bony spur by. You can see this is a special diamond drill which I am using, and there should not be any cottonoids around because at times the cottons get stuck and then it causes damage to the cord. Very slowly under high microscopic zoom, you need to drill the bony septum very carefully, and you have to go up to the vertebral body level to excise the spur as completely as possible. And on this side is the cord on my side, which I don't see as yet because this is actually hidden, because the septum is always oblique and the orientation of the spinal cord is oblique. This is the medial dural sleeve on the other side, and that's the sleeve on the other side. So this type 1 split cord malformation surgery is one surgery I advise it should be done only by surgeons who have done enough cases in operating in these patients, because it does require a lot of training and expertise, and it should be done in safe pair of surgical hands. So there is more of a cartilaginous part of the bony septum lower down, which I am gradually removing by using scissors, rongeurs, diamond drill, and a combination thereof. So you can see after doing this, there is so much of bony spur still left. The big one, almost 3 millimeters. So I further take my special diamond drill, pneumatic drill, which I use very carefully, and I don't go near to the cord at all. So you can see this is the hemichord. Can you see the beautiful? This is the left. This is opposite me. So this is the right hemichord, and these are the roots which are coming. Now we have started seeing the roots. You have to use copious irrigation. And now you have started seeing the hemichord on the left side, which is the side where the surgeon is standing on the table in the prone position. You can see, and this cord is smaller in size. If you see it very carefully, This is smaller as compared to the right hemichord. And so you clear off all the blood, and this bony spur is taken out, and the median septum on this side and this side is actually united. You can see now beautifully the right hemichord and the left hemichord, and you can started seeing the roots now on the both the sides. And this is the medium septum being united and made into one. So you convert two dual sheath into one dual sheath, and then subsequently you go down, open down further, and this is the direct nerve stimulation being attempted. This is a nerve stimulator to stimulate the nerve directly, and then comes that you have to release the tethered phylum terminal. The color of the phylum terminal is different as compared to the roots, and there is a leash of blood vessels which is going in the front and at the back. This is the phylum terminal, which is actually thickened. You can see a tiny streak of blood vessel going in the front, and there will be another at the back. So this is actually tethering the cord then. So what we do is, if possible, through the same, or in some cases through the separate incision, we have to cut this phylum terminal. Again, a word of caution: you have to do the neuro monitoring before. You have to isolate all the tiny rootlets on the under surface of the phylum, because it has been seen the sphincter fibers, they actually run on the under surface of the phylum terminal. So you have to separate and spend good amount of time in releasing that phylum terminal, separating the fibers, and then you close the dura, put some glue at the back, and these are the nice MEP recordings coming at the end of the surgery, which is very, very reassuring to the surgeon that the surgery has been done. Now this is the child. You can see the child is moving the limbs well after the surgery. So this is how the pictorial representation looks like. So to revise the steps, you have to define the abnormal bone is exposed, and the laminectomy is done all around. And you have to define the upper end, the sides, and the lower end. And if there is any associated anomalies, like in this child there was associated meningocele, that needs to be addressed. And one needs to be very, very careful with the bone drilling, avoid any cotonites, and use diamond drill at the depth. And all the extensions which are from the dural pouch to the spinal cord, which is called as a meningomyelocele manicular, that needs to be excised under intraoperative. Usually these are the dead tissues, the paramedial nerve roots, they do not carry any important function. However, you should do continuous recording either with the coaxial or with the monoaxial leads of doing intraoperative neuromonitoring. So one needs to be very, very careful at the lower end and at the site where the septum is close to the spinal cord. And the pia arachnoid bands which are there, they need to be excised, very, very careful. This is the caudal margin, and you need to be very, very careful at this area. And this is my neurophysiologist who is continuously doing the monitoring and stimulations after every few minutes to guard me and to tell me that everything is reassuring while I'm doing the surgery on these children. So the ventral dural closure, some people close. I often try to close if I've got enough dura to close the ventral dura. Of course, the dorsal dura needs to be closed, but some people, they just leave it open. It is purely optional, but however, I close the ventral dura in a large majority of my cases. And this is the child looks like after the surgery. So when they come to you for follow-up, you need to evaluate these children whether they are able to they got any deficits or not. This is a separate child. This is not the child I operated. This is another child I operated 7 years back, coming to my OPD, and you can see the post-operative image.
Excision of the spur and ripping of the dual.
So this is how the phylum sectioning. So the oblique septum, as I mentioned, the problem with the oblique septum is that they usually have got asymmetric cords, and the larger hemichord which is there, which is usually the first to be encountered, it has got one set of lateral ventral and the two dorsal roots. The smaller hemichord usually has got one ventral root only, which is usually vertically located and hidden and delicate, and it is this hemichord which is at the highest risk of deterioration during handling or manipulation. So one needs to avoid jarring of the smaller hemichord with spur during removal to prevent any deficits. And as I mentioned, these are type 1D spurs which are technically quite challenging to the surgeon. One needs to be very, very careful in management of these cases. And this is what our result was published, and this is how the type 2 split malformation looks like. So this is a 5-month-old child with a lipomas and type 2 split cord malformation. You can see there is a fibrous septum which is causing the tethering of the cord. This is how the septum actually looks like coming from the dura. So this septum needs to be divided. So this is what actually is being done. Once you divide this septum, then you see the child has got associative low lying tethered cord. And see, this is now the septum is completely divided. There is no bony spur in this patient. There is a single dural sheath. There are no two separate dural sheath. You can see lower down. You can see a bulky, huge, voluminous, fatty phylum terminal. And so this phylum terminal needs to be divided under constant neuromonitoring. And this is the big phylum lipoma, which is excised completely in this child, and the child made a complete recovery. So the problem with our country, and in fact most of the developing nations, is that the preoperative or the prenatal ultrasonography diagnosis of the neural tube defects is either not done in most of the places, especially far off areas, the countryside, or it is often missed. And the patients, they usually present to you very late. And the AFP and the ACE levels are not usually done, which can help in the prenatal counseling. And so basically, to follow up the conservatively managed cases, it's quite a challenging risk. You can say that type 2 split cord malformations, they do not require any surgery, but these patients are usually lost to follow up, and they come to you when they have got established severe deficits. So you need to take a decision whether if the patient is unlikely to come to a follow up, and you can do the surgery safely without any deficit. Even type 2 SCMs should be offered some surgical intervention for tethering. And the other biggest problem which I'm facing, which we all are facing, we have got limited number of pediatric neurosurgeons doing regular split cord malformation surgeries. So a carry-home message I want to give to all is that all split cord malformation type 1, whether they are symptomatic or asymptomatic, should be operated prior to deformity corrections or with or without deficits. The type 2 split cord malformations, if they do not have any symptom, then it remains entirely optional to the surgeon based on his local practice and his surgical decision. Thank you.
Very good, comprehensive, well illustrated talk. Thanks, Dr. Gupta. We're running a little late, but we have any quick questions or comments for Dr. Gupta, Manas, or Norma? Good morning, Manas. How you doing? Or good evening. How you doing?
Yeah, morning. Doing well. Deepak?
Yes. Hi. Good morning. Good morning,
Yeah,
Manas.
yeah. Good morning. I just missed the slide on how many people improved in their motor and sensory and their autonomic symptoms. How many children?
Usually, the motor improvement is seen approximately 40 to 60% of the cases. The sensory improvement is seen more. It is the pain which improves the maximum. The pain improves as many as 60 to 90% of the cases. Then is the sensory symptoms, the motor, the bladder symptoms, they improve the least. The improvement in the bladder symptoms, I would say, is to the tune of 20 to 30%.
And when the patient comes for follow-up with persistent pain, when do you reinvestigate for looking for retethering and all that?
Well, it remains quite debatable. Usually, I do my first MRI after the surgery at the end of 6 months. As I mentioned, I really have not come across my children coming back to me with pain because of retethering. Because the improvement in the pain is the first symptom I usually notice. And I'm not very aggressive in diagnosing retethering very early on. Only when these children, in association with pain, they have got other symptoms with the motor worsening or the bladder worsening, then only I take a call on whether to operate for retethering of the spinal cord.
Very good. Very good. Any other comments, closing comments, or questions?
Yes, good morning, sir. Good morning, sir.
Go ahead.
I just have two quick questions. One is regarding a type 1 split cord malformation. There are many patients wherein the septum is so asymmetric and is displaced to one side and reaches and fuses with the lamina. So the relationship between the hemichord and the grossly deformed, deflected septum, which is fused to the lamina, makes the drilling extremely difficult. And especially if it is very close to the lower crotch of the split cord. So while drilling, the heat generated by the why the drill might be a source of damage. That's a word of caution. And in those cases where there is a asymmetrically situated septum which is fused to the lamina, are there any special techniques which you adopt to avoid damage to the hemicots?
I usually do a wide exposure, at least minimum 2 levels up and 2 level down. I use my laminectomies to very separate to separate to dissect out the lamina from the underlying spur. And in the top part, when I'm very sure that there is no spinal cord is likely to be very deep, those places I use my drill. And as you mentioned about the drilling in the lower part where the union is there, yes, you need to be very careful in using your drill. I usually use the diamond drill, and I'm sure you will agree to it that it is purely surgical expertise and the experience which counts in prevention of deficits. So this is one surgery I strongly say it is not meant for the beginners or for somebody. Somebody has to be doing these cases on a very regular basis to obviate the deficits.
While using drill close to the cord, hemicots, do you use cooled saline to reduce the distribution of the heat?
Yeah, I'm sorry, I missed out saying it out. My resident is there's a cold line which is connected to IV cannula, and it is put on continuous flow, and it is flowing continuously over the area of the drilling. And I use my drill to very less extent. I don't use it extensively. Only in the deeper part, I use my drills, that to diamond drill, and there is always a sheath of dura or the median sleeve on either side. Inside that sheath, I do my drilling, and subsequently I use my bony, the very thin, very small bony punches to nibble of the bony parts.
A quick question regarding a type 2 split cord malformation. There are a few patients wherein the additions between both the cords are so tiny that you do section them, but then you sometimes we feel maybe they may not be a great source of tethering as it is made out in the literature. What's your take on that?
So I usually, my training by Professor Mahapatra is that all bony elements they need to be taken out because they are definitely source of tethering. In type 2 patients, in case I've got a bony spur and a very high up type 2, I usually don't chase the type 2 with a bony spur. But if the local level, the bony segment, the bony spurs, I am very aggressive in taking it out.
Very good. Okay, we're running a little late, so we're going to wrap it up here, Deepak. Thank you very much. And we'll stick around for Manas's talk in the next hour. Thank you very much, everyone.
Thank you.
Okay, now we're going to stop that, and we'll start formally Manas's talk. And we'll edit it so that it's clean, a separate video. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening, this is Dr. John Bennett, televising from Miami for Neurosurgical TV in collaboration with Deepak Gupta for Department of Neurosurgery of the Ames Hospital in New Delhi. Today we have the pleasure of having Manas Denigrahi, MD. He's going to talk about endoscopic management of hydrocephalus. But first, let me briefly introduce the panel. Hello, Deepak.
Hello. Good morning. Good morning, Dr. Manas.
Good morning.
We are very happy that you agreed to join us at this platform. And this is a very innovative and a unique concept of educating the doctors all over the world. Many doctors may not be available online to talk to you now, but some of them are watching, and this program is being live streamed to different channels. And the beauty of this thing is that the people will be able to see what you talk now as an educational video for a very long time on YouTube. And I must say that Dr. Manas Panigrahi is a very accomplished and a fine neurosurgeon and from India, and he has got a huge amount of experience in endoscopic procedures. And we look forward to listen to you, Dr. Manas Panigrahi, and thank you very much once again for joining us.
Very good. Natararan, can you introduce yourself, please?
Yeah.
Hello, Natararan. Could you please introduce yourself? Can you hear me okay?
Dr. Muthukumar?
Oh, I guess not. You're muted. Could you introduce yourself, please? You're muted. You're muted. Okay.
I'm just. Are you able to hear me now?
Yeah. Okay. Yes. Could you introduce yourself, please?
Yeah. I am Dr. Muthukumar. I am the professor and head of neurosurgery at Madurai Medical College, Madurai. I have a special interest in pediatric neurosurgery. and it's great to be a part of this panel. Thank you.
Great. And Chandrasekhar, you just arrived. Can you hear me okay? Can you introduce yourself? I guess not. I guess maybe we'll wait till later. Okay, Manas, thank you. Thank you for being. Okay, are you there now?
Yeah, I'm ready.
Yeah, could you just say hello?
Hello.
Dr.
Can you hear me?
Okay. Manas, sorry we're late. Go ahead, it's all yours.
Okay. Can you hear me?
Yes, I can.
Okay. So thanks Dr. Deepak and Dr. Muthukumar, and thanks Dr. John for making this possible. This is a channel where we can speak at our own convenience, and the learners also can learn at their own convenience. Even if they are not there, as it's available in YouTube, it shall be used by many people. My topic is on endoscopic management of hydrocephalus. We have been doing endoscopy since 2001. Over the years, we have learned when to do and when not to do. So I'll take case examples of the cases which we have done, and then and give principles for the upcoming neurosurgeons or trainee, that which are the right cases to do to treat hydrocephalus in endoscopic way, and which are the right cases to do a shunt. Now this is how we manage. If a child comes with hydrocephalus, with lateral dilatation of the lateral ventricle and third ventricle, the first thing if this child had come in like in 1910, we would have thought of doing endoscopy. Endoscopy is not a new method of treatment. It's an old method. Like many diseases of neurosurgery which are treated, like if you take Parkinsonism, it started with surgery, then came medicines, and then again surgery has crept into it. Even in epilepsy, it started with surgery, then we had a lot of anti-epileptics, again now surgery has crept in. Similarly, in hydrocephalus management, the first thing to was an endoscopy, but then it was not popular as the equipment was not very good. So if a patient came in 1910 to till 1940, people still used endoscopy, and John Mixter was the first to do endoscopic third ventriculostomy in 1923. It is in 1952 when speech first came with using a VP shunt. And this, after 1950, people were a little skeptical of endoscopy as the results were not so good. Until recently in 2000, there are a lot of papers came in 2001, 2004, and 5, where they demonstrated that third ventriculostomy, endoscopic third ventriculostomy, was superior to ventricular peritoneal shunt, especially whenever there is hydrocephalus associated with tumors. And this was possible because we had newer imaging modalities, we had a better camera, better endoscope, so the visualization was better, and hence the complication came down. In 2007 and till now, 2016 also, there are a lot of papers have come comparing whether which is superior, whether endoscopy or ventriculoperitoneal shunt. When endoscopy came, it was promoted as that endoscopy is the panacea, not it is the gold standard of treatment. But the failure rate of endoscopy is almost 26% or 30% in 3 to 5 years. And similarly, the failure rate of VP shunt was 42%. So, in the conclusion of this paper was endoscopy was better than VP shunt. Similarly, there was another paper by Kulkarni et al. When it was done by the Canadian Pediatric Neurosurgery group. When they compared the role of endoscopy versus shunt, they found that the risk of surgery was higher in the initial 3 months in endoscopy, but then over 2 years, the failure rate is half to that of, as you can see in the other paper also. So if you see these two papers, it appears that endoscopy is superior than shunt. But then endoscopy is not the right treatment for all the cases. So if a patient comes how to decide that which is a case for an endoscopy. Now this can be done by using a ETSS score, which was published by again Dr. Kulkarni in 2010. Now what he took is he divided them into, he took the age and the etiology and the previous history of shunt. If the age was less than 1 month or 1 to 6 months, it was score was 0 to 10, and if the previous shunt was there, it's 0, and no previous shunt is 10. So when you add up all these three scores, whenever the score was more than 80, then the success rate of endoscopy was higher than the shunt. So these group of people will be benefited with endoscopy. Whereas whenever the score was less than 70, then shunt and endoscopy had similar results. So, and if the child is less than 6 months, shunt was superior. So it's not essential that any child comes with hydrocephalus, they have to be treated with endoscopy. One has to do a proper evaluation whether he had a previous shunt or not, what is the etiology of the hydrocephalus, and what is the age of the patient. Depending on that, decide whether the child is better to undergo endoscopy or a shunt. Now, once we decide for a particular child to go for endoscopic shunt surgery, I'll show a small video of how to do the endoscopic shunt surgery. Now, the first step in planning an endoscopic third ventriculostomy is planning the proper burr-hole. Because if you miss the burr-hole, then one cannot enter the foramen of Monro in the right angle, and there are chances of damaging the fornix or the thalamus striate veins. So the first one has to study the sagittal image of the child, then draw a line from the tip of the dorsum through the center of the foramen Monro and project it onto the skull. Wherever it reaches, that is the point where one has to make the burr-hole. And then when one enters through that burr-hole, as you can see in the diagram, we can do a third ventriculostomy without damaging any structures. So once you have it projected, on the MRI, one can measure the distance from the nasion to the projected line and plan the burr-hole at that place. It's not essential that all the time you do a pre-coronal burr-hole, as many children come with a deformed head, and using a standard burr-hole may land up in problems. Before doing a third ventriculostomy, it's essential to know the anatomy of the floor of the third ventricle. So the floor of the third ventricle, if one goes from the anterior to posterior, it starts with the optic chiasm, then you have the infundibulum of the hypothalamus, then you have the tuber cinereum, then you have the mammillary bodies, and then the posterior perforated substance and midbrain. Now, the third ventriculostomy is done in the pre-mammillary area. One can see that just in front of the mammillary body, the top of the basilar artery also is situated. So while making a hole, one is to avoid the basilar artery. Always make a perforation in front of the basilar artery to prevent vascular damage. Similarly, if one looks from the floor of the third ventricle, like this is the mammillary bodies, this is the pituitary stalk, and this pre-mammillary area is the safe zone. So in front of the basilar bifurcation and behind the infundibular recess is a safe zone where one needs to do the third ventriculostomy. As you enter a lateral ventricle, the first thing you see is the foramen of Monro. The foramen of Monro is bounded by the fornix anteriorly and superiorly, and one identifies the choroid plexus, one identifies the thalamus striate vein and the septal vein. If one follows the choroid plexus and septal vein, wherever it joins, one reaches the fornix. If as you enter the third ventricle, if you do not identify the foramen of Monro, follow the choroid plexus anteriorly, and wherever it joins the thalamus striate, in front of it, you'll find the foramen of Monro. Usually it is done in a supine position. The head is kept at 20 degrees elevation. The operating table is kept at a lower level so that you can place the endoscope and work comfortably. and look at one has to look at the ergonomics of the surgeon also. And the burrhole is planned, as I have already explained. Draw a line from the dorsum celli through the center of foramen and project it onto the skull. Yeah. This is an endoscopic. This is a video of a third ventriculostomy, where as soon as you enter the ventricle, you see the choroid plexus, the septal vein, the thalamus striate vein, and then enter the foramen of Monro. Usually a 0-degree endoscope is used, which is 4 mm diameter. As you enter, pass through the foramen of Monro, one will identify the floor of the third ventricle. Now this red color dot is the infundibular hypophysis, and this ridge is the dorsum celli. These two ovoid except structures are the mammillary bodies, and these two structures, red color pulsating structure, are the tip of the basilar artery with the bifurcation. The safest area is in front of the basilar artery and behind the dorsum celli or the infundibular hypophysis. Once you make a perforation, one has to dilate the foramen using a Fogarty catheter. Now the perforations can be done with a sharp instrument, with a Caesar or endoscope itself, or the Fogarty catheter. While dilating the Fogarty catheter, it's better to keep for 1 minute so that you achieve hemostasis while removing the Fogarty catheter. Once the hole is done, minimum 5 mm dimension has to be achieved. One has to pass through the osteotomy, see that one sees the basilar artery and the bifurcations. As many times one can find a second membrane, and if one does not perforate that, there is a high chance of failure of third ventriculostomy. It's not easy all the time like this to perforate the membrane. Like in chronic hydrocephalus or a post-meningitic hydrocephalus, as you can see in this video, it does not. Yeah, it is not easy to perforate as we do. If the Fogarty catheter, you cannot perforate with the Fogarty catheter, then one can use Caesars or bipolar, and some people use ultrasound also to suck. So here it was difficult because the floor of the third ventricle was thick, and it's opaque also. Many times it's not seen where is the basilar artery. In these cases, one can use an ultrasonic Doppler if one has, or use to if you do not have a Doppler, one has to do the perforation directly on the feeling the dorsum celli. Cutting on the dorsum celli, one is safe and you can avoid damaging the basilar artery. Once you perforate with the Caesar, the osteotomy can be enlarged by a Fogarty catheter. The Fogarty balloon has to be dilated gradually, kept for 60 seconds to 20 seconds, so that there is hemostasis is achieved. And you can see here, after dilating the floor of the third ventricle, still there is one more membrane inside. We do not see the vessels here. So in these cases, one has to perforate the second membrane also. The success depends on visibility of the naked basilar artery like this. So if one sees the basilar artery, the success rate goes to 80%. In 2001 and 2000, we had published the microscopic anatomy of the Liliequist membrane in relation to the endoscopic anatomy in minimal in 2000 and 2001. The Liliequist membrane, which forms the second membrane, has two sheets. One has a diencephalic membrane, one is a mesencephalic membrane. Now this shows the diagram that this is the Liliequist membrane. It goes from the dorsum celli to the premammillary area till the mammillary body. Now and this has two sheets. The second membrane can go from the dorsum celli to the midbrain or the tectum. So when even this membrane is very thick, then the CSF, even if one makes a hole here, CSF doesn't come down to the cistern. So So one has to perforate the floor of third ventricle as well as perforate the liqueous membrane if it's thick. And if there are two membranes making a perforation behind, again there will be a failure of endoscopy. So one always has to make in front so that the basilar artery is seen. If you can see the naked basilar artery, that means you have done the perforation of all the barriers or all the membranes. It is the concept of third ventriculostomy came as we thought that there are no neural structures in the floor of third ventricle. Now, there was a paper in 2012 where they did histological analysis of the third ventricular floor in non-hydrocephalic patients and hydrocephalic patients. Now, what they found was that they compared 5 cadavers with hydrocephalus and 5 cadavers without hydrocephalus. What they found was that the number of neurons or the cell bodies are similar whether it is hydrocephalus or non-hydrocephalus, and the floor of the third ventricle or the premammillary area is not devoid of neuronal cells. There are some cells. And whenever one makes a perforation, because of traction, one can damage the nuclei in the lateral wall of third ventricle, and this can cause potentially complications in the surgery. All of us know that endoscopic third ventriculostomy has a chance of developing diabetes insipidus. They can develop memory disturbances due to pharyngeal injury or damaging the nuclei also. Now, if one performs the third ventriculostomy anteriorly, they can cause diabetes insipidus. They can have thermal regulatory disorders and cardiac arrhythmia. Many of us have experience of bradycardia while doing the third ventriculostomy. Even if the perforation is posteriorly, there is a higher risk of personality disorders, memory disorders also. In addition to do third ventriculostomy, hydrocephalus management also involves treatment of the primary cause. If you have aqueductal stenosis, one has to do an aqueductoplasty. And if you have a tumor, one has to take care of the tumor. And if you have a cyst, one has to take care of the cyst. My consequent slide will be on the management of the etiology. I told now the symptomatic management, diversion of CSF. Now I'll be talking about the management of the etiology of the hydrocephalus. Now this is a video again of the third ventriculostomy. The anatomy is clearly seen. The bifurcation of the basilar, the mammillary bodies. I pass the endoscope posteriorly and identify the aqueduct. Here you can see here the aqueduct is sorry. Here the foramen mater is quite wide, and the septum pellucidum is absent.
Are you okay, Manas?
Yeah, I'm okay.
Okay.
Is it coming okay?
Yes,
now,
yes, good picture.
Puncturing the aqueduct with the monopola, as it was very tough. You see the posterior fissure, the suprapineal recess, and then doing an aqueductoplasty with a Fogarty catheter. As we know that the diameter of the aqueduct is 2 to 3 mm, while in inflating the Fogarty, one should not do it more than 3 mm diameter, otherwise it can cause gaze paralysis. Now this is another case of hydrocephalus due to a cysticercal cyst, where the cyst had migrated from the third ventricle. When it did an MRI first, it was in third ventricle, but when it did an endoscopy, it had migrated into the fourth ventricle. So we had to through the aqueduct, we are extracting the cysticercal cyst with just a suction aspiration technique. This is a standard central venous line we are using as an instrument to hold it. And the cyst is punctured and delivered out through the aqueduct into the third ventricle, and you can see the aqueduct is empty now, and the cyst is along with the endoscope, it is pulled out into the for biopsy. Now, what does one do for tumors associated with hydrocephalus? Now, if one has a pineal tumor with hydrocephalus, one can do a third ventriculostomy as well as a biopsy of the third ventricle of the tumor. But the prerequisite is the third ventricle should be wide. As all for endoscope sheath is almost 6 mm, it is important that the width of the third ventricle should be minimum of 6 mm, and the width of the foramen Monro also should be 6 mm to plan a biopsy procedure. If it's narrow, or the third ventricle is narrow, or the foramen Monro is narrow, then it's probably better to avoid endoscopic third ventriculostomy. So this is another 42-year-old female who came with ocular signs with unsteadiness of gait, and the scan showed a posterior third ventricular tumor with wide third ventricle, more than 6 mm. That is a prerequisite. And the foramen Monro also should be wide before one plans a biopsy. And I can see here the foramen Monro is wide. So then these are the right cases for doing third ventriculostomy and biopsy together. When I did an endoscopy, there was already a spontaneous third ventriculostomy in this patient. And then we went back to identify the tumor. You can see here the interthalamic adhesion. Here the tumor is seen bulging in the posterior part of the third ventricle. The aqueduct is anteriorly like a crescent shape. Instead of using monopolar or bipolar to coagulate, you use the Fogarty catheter as a hemostatic agent also. We insert the Fogarty catheter into the tumor and then inflate it. If you inflate, it acts like a Caesar, like opening up the tumor, and automatically it has achieved hemostasis also. You can see here, you're just waiting for the right angle to enter into the tumor and then inflate the Fogarty catheter. We try to reduce the number of instruments, like one can use monopolar, bipolar to coagulate, but it increases the time, the number of instruments used. So with one Fogarty catheter, it helps like a Caesar, like a hemostatic agent. Once you insert Fogarty catheter, then again we widen the balloon, dilate the balloon. This is the aqueduct, this is the posterior intercommissure. And you can see here the tumor, there is no bleeding. The tumor, the ependyma is open, and now it is easy to take a biopsy. You take the biopsy forceps. Here, cut incise the interthalamic adhesion to have an access. And then biopsy is taken. And if there is bleeding, again, Fogarty catheter can be used and inflated there to achieve hemostasis. This turned out to be a germinoma. Now, these are cases where you can do without navigation. There are few cases where navigation is useful in endoscopy, especially when you have a narrow foramen of Monro, or you have asymmetric skull and ventricle, or suprasellar arachnoid cyst, or one plans two procedures like third ventriculostomy and biopsy, or when the thick floor of the third ventricle is thick, like in post-meningitic hydrocephalus or a chronic hydrocephalus, in multiloculated hydrocephalus, or biopsy of paraventricular tumors like thalamic tumors or caudate tumors. I'll take examples of these cases. So normally we calculate manually the burr but if one uses navigation, one can always use the reference pointer to plan your burr and trajectory. But usually you don't do it regularly. Now this is a case of a post-meningitic hydrocephalus. If in a cases of post-meningitic hydrocephalus, we normally get a contrast MRI in all the patients. And if the floor of the third ventricle is enhancing. You can see here that it's thick and enhancing. Then one can predict that during surgery it will be very difficult to perforate. And these are the cases we try to use navigation to find out the basilar artery. And these are the cases we try to avoid doing surgeries also. As if the floor of the third ventricle is very thick, then for the success rate of third ventriculostomy comes down drastically. Unless the patient is explained that the success rate will be less, but if they insist on surgery, we do third ventriculostomy in these cases. So it's essential to do contrast MRI in post-infectious hydrocephalus. Now this is another girl who came with the hydrocephalus due to suprasellar arachnoid cyst. Now you can see here the arachnoid cyst, and in the side set you can see the bulging arachnoid cyst into the lateral ventricle also. The procedure what we plan is to do a cystoventriculostomy as well as do a cystocernostomy. Now most of the time, when once you do a cystoventriculostomy and enter the suprasellar cyst, the floor of the third ventricle is very thick. It's very difficult to identify the basilar artery or the mammillary body, and so in these cases again navigation helps us to plan where to make the cystocernostomy. Sometimes we do the MR angiogram and we superimpose the MR angiogram on the navigation, so that it helps us in the navigation can help us to avoid the basilar artery here. You can see here the basilar tip of the basilar artery, and then can plan the perforation in front of the basilar artery. Now this is a video of the same case where we enter the lateral ventricle. We have already punctured the cyst. You can see here the cyst is punctured, the it's collapsed, and the next step is to, you can see here the aqueduct is seen because the cyst is punctured, the third ventricle is open. But still we wanted to prevent recurrence of the cyst, wanted to do a cystocernostomy. Here you can see that for the floor of the third ventricle, it's coming into the third ventricle. You're checking if the aqueduct is patent or not. And next step is to find the cystoventriculostomy. Through that we are entering the cyst. We entered the suprasellar cyst. This becomes a difficult task as if the cyst has already collapsed. Many times it becomes difficult. So one has to have a little bit of patience. Fortunately, in this case, the floor of the third ventricle was easily, you can see here the floor of the third ventricle thick membrane which are perforated, and you can see the pons beyond the floor of the third ventricle. There is still another second membrane which are trying to perforate. Till we do it till we find the basilar artery. The other indication of doing navigation is multiloculated hydrocephalus, like in this case. And once you do a navigation, you can plan the septostomy, and you can be sure of doing that you have communicated all the loculi. Otherwise, if you do not do navigation, it is like a presumptive evidence that we have communicated all the loculi. The other indication is biopsy of tumors, like these tumors of the thalamus or the pulvina, where the third ventricle, also the anterior part of the third ventricle is open. In this case, we did a third ventriculostomy as well as did a biopsy of the thalamus, so that we avoided a second procedure of doing stereotaxy biopsy, and we didn't do a shunt also. So one single procedure of third ventriculostomy and biopsy of thalamus, and depending on the report, biopsy report, we went ahead giving radiation for this patient. Now, in adult patient, one can use the optical, but in the optical with shear track, one needs to fix the head. In children, we use the electromagnetic EM systems, axiom system of Medtronic, and so that one can one need not fix the head, and if shunt is required, it can be done easily. This is how we place the patient. If we plan to do in multilocular hydrocephalus to communicate all the cyst and the cistern, so in the EM system it becomes easy. We can fix the reference frame or fix with a sticker also. The shunt tube tracker which they give to insert a shunt, this is not FDA approved, but they use the shunt tube tracker inside the shunt, and then automatically our endoscope becomes like a navigated endoscope. You can see here it works like a navigated endoscope. So this is how the endoscope. This is an irrigation channel, this inflow channel, outflow channel, and you have the shunt tube tracker in it, so that one can track the endoscope and do the perforations as and when required. Again, this is the intra pictures. As you enter, it directs us where you have entered and where to do the perforation. Now, this was a case of asymmetrical lateral ventricle dilatation. You can see here the septum is pushed to the contralateral side. This is a case of a foramen Monro block. So here we planned septostomy, and we used again navigation so that we could we confirm that they have entered the opposite ventricle also, and you can plan the septostomy point also. This is a video of a septostomy. Anyway, the video doesn't open.
Okay, try clicking twice.
Okay.
Didn't work.
Yeah, it doesn't work.
Okay.
Okay, maybe at the end of presentation I can go back to the source file and so.
Okay.
Yeah. So as I explained you, in patients with narrow foramen of Monro, like this patient who had a posterior third ventricular tumor, and the floor of the third ventricle also is thick, and in addition the foramen of Monro was very narrow. In these cases navigation helps, and if still during surgery you find that it's inadequate, then one can use a pediatric endoscope, and if still it doesn't work, it's better to come out rather than damaging the foramen or causing any bleeding from the thalamocaudate veins. If the foramen is narrow, one can also plan instead of doing a single burr and trying to manage with one trajectory, we have done with two burrs, one for the third ventriculostomy, and one for the tumor. This is another tumor, the posterior third, where we take the anterior border of the tumor, then draw a line through the foramen Monro and project it on the skull and make the burr here, so that one can have a direct access to tumor biopsy. So in cases where we are planning so that in one burr it is not possible, we make two burrs. Like this patient with the one small flap, we make two burrs so that the neural damage can be minimized. Yeah, this was a video of the biopsy of a posterior third ventricular tumor, but I've already shown this, so I'll omit this video. Now, once one has done the third ventriculostomy, how do you follow up the patient? When you do a scan, the ventricle size doesn't come down; it appears same. It's only third ventricle comes down in 33% of the time, and lateral ventricle comes down in only 16% of the time. So, but what is important is to realize that the sulci has opened up, the cistern has opened up, the PVL has come down. So many times the patients get confused and they get worried that the ventricle size has not come down, but they have to reassure that all the cisterns are opened up, the PVL has come down. It's only in 1/3 of the patients only it comes down. It almost takes 2 to 3 months for the ventricle size to come down. Once you have done that, how do you decide? How do you follow up the patient? It's not once the patient is come for follow-up, 2 to 3 months, is asymptomatic. It's not we should not tell that you are fine, you need not come back. As many times the stoma what you had created can close at a later date also after 1 year or 2 years. So it's important to do a phase contrast MR, CSF flow across the third ventricle, end of 3 months, and then yearly. If one finds that the stoma is closed, one has to redo third ventriculostomy or think of doing a shunt if required. As to this can prevent the many times the sudden deaths which have been reported because of stoma closure which is not detected, and patients come with sudden ICP and sudden death. People compared whether the results of third ventriculostomy is dependent on the experience. Now, Dr. Vogel, he reported his result. In first 33 cases, he had a success rate of only 58%. Whereas in his last 33 cases, he had a success rate of 82%. Experience counts, and the experience of is not only the technique of how you do, but selection of the cases. You can see here the risk factor. He has reduced the cases, number of cases he did because of CNS infection or myelomeningocele in his last 33 cases. And even if there is associated intraventricular hemorrhages, he has reduced the number. So the results depends on the technique which you learn over experience and the indications. Again, over the time, we learn that it's only aqueductal stenosis and hydrocephalus due to tumors have the best results, but when it comes to post-infectious or post-myelomeningocele or intraventricular hemorrhages, shunt is equally good as endoscopy. If a patient comes with a shunt, malfunction shunt, do we have to go for a third ventriculostomy? Now, if the cause is due to aqueductal stenosis, it's always worth doing a third ventriculostomy instead of revision of shunt. The outcome rate following third ventriculostomy following a shunt varies from 40% to 80%. But the complication rate is a little higher. But if it's due to in India where a lot of people TB meningitis come, in those cases probably revising the shunt probably is not a bad option, as the risk is higher and the shunt-free outcome also is not as good in those cases. When they analyze the causes of early failure of ETV, the most common cause has been commonest cause of early failure is infection. The second common is hemorrhage. So if you have infection and hemorrhage, and you can keep repeating that, because whenever you have these cases, it's better to avoid third ventriculostomy. Otherwise, the technique will go into disrepute as telling that endoscopy doesn't work. But whenever there's an aqueductal stenosis or due to tumor, the failure is very less. It's like less than 20%. So the best indications are aqueductal stenosis and tumor. So even if you decide the best indication, the 5 years patency rate is only 70 to 80%. That is what the patient has to be told, as most of the time they think that shunt block and third ventriculostomy is a panacea. It is not true. Stoma of third ventriculostomy also can close after 3 to 5 years. Once you have done the ETV, patient also has to be explained that there is the roughly patency rate is 70%, and the early failure within 2 weeks can be due to incorrect technique or due to when you have not perforated the second membrane or you have not seen the basilar artery, or improper selection of patient. And the late failure can occur after many months. That is why it is essential that one has to do a CSF flow study across the floor of third ventricle every year. And if one detects there is a change, it's better to do a redo third ventriculostomy. But third ventriculostomy can also fail because of non-absorption of arachnoid granulation despite good flow across the third ventricle. If one finds a good flow across the third ventricle CSF flow and still the hydrocephalus is not resolved, then these are the cases when one has to do a shunt as absorption defect. So the failure of third ventricle can be because of reclosure or narrowing of the ventricular stoma, and this has to be detected early and treated. Otherwise, one can have this sudden deaths. Many child can have will be found dead at home. After doing all this, what is the outcome? The outcome varies whether depending on the age. In adult patients, the outcome has been almost 77% had good improvement in clinical outcome. But again, it's due to adult onset acute stenosis or tumor associated with hydrocephalus. These are the few papers on the success rate of different in different series of adult patients. It has varied from 70 to 80%. Whereas in children, it's not so good. In children, the 70% the 1 year and the 5 year success rate has been 65 and 52%. So while counseling the patient, they have to be explained that the 1 year outcome is 65 and the 5 year survival is 52, and after 5 years he might need a redo third ventriculostomy and may need a shunt also. In infancy, as you can see here, if it's less than 6 months, the success rate comes down drastically to 30 to 40%. Only few people for less than 1 year and 1.5 years also have got results of less than 50%. So it's probably better to avoid the third ventriculostomy less than 6 months, unless it is due to acute stenosis, where from even the children from 3 to 6 months also the results are good. Now, this is the recent paper in 2016 where they compared this is a multi-center comparison of third ventriculostomy versus shunt for infantile hydrocephalus. And the conclusion in this, there are 115 cases of third ventriculostomy and 43 of shunt, and the age group was 3.6 to 6 months. And the conclusion was that the shunt has a superior success rate than ATV. So at the present stage, if a child comes with less than 6 months, it's probably better to do a shunt than third ventriculostomy, and third ventriculostomy should be reserved for older patients. This is roughly the conclusion of the outcome. If it's less than 1 month child, the success is only 30%. 1 to 6 months is 50%. If 6 months to 24 months, it's 70%. But if it's older child, more than 24 months, it's almost 80 to 85%. Now, endoscopy third ventriculostomy doesn't go without complications. This is a meta-analysis that the meta-analysis of many papers. They say that the complication rate has been quite not bad. Like if the bleeding rate is almost 3%, 3.7%, and the bleeding due to basilar rupture is almost 0.2%. There also has been in complication due to neural injury like thalamic injury, fornical injury. You have midbrain injury also, and anesthesia-related complication. And in this, 4% had to be abandoned because of they couldn't complete the procedure or because of the bleeding. And like shunt, there are chances of permanent morbidity in third ventriculostomy also. This meta-analysis of almost 3,000 patients, there's a permanent morbidity of 1.44%. Usually it is gaze palsy or loss of consciousness and memory disturbances, as I told you, depending on where you perforate the floor of the third ventricle. If you do more posteriorly, they'll have memory disturbances. If you do more anterior, they have high chance of developing diabetes insipidus. There can be weight gain, there can be precocious puberties also. So one has to be careful and counsel the patient that there can be a lot of hormonal changes, and few people can have memory problems with third ventriculostomy. So the complication rate probably will come down with experience, but this paper they analyzed with series which had less than 100 patients and series which had more than 100 patients. But the overall complication rate did not differ much with the series which had less than 100 or more than 100. And in adults and children also, the complication rate and morbidity rate has not been significantly different. In conclusion, endoscopic third ventriculostomy can be regarded as a low complication procedure with an overall complication rate of 8.5% with a permanent morbidity of 2.4% and mortality of 0.2%. And if one does in the properly selected cases. In conclusion, success of third ventriculostomy depends on the patient selection, like aqueductal stenosis or tectal tumors or tumor-associated hydrocephalus. However, because of the high rate of failure and complications, ETV in shunt has to be the first line in children less than 6 months and third ventriculostomy in older children with the above indications. Thank you for your attention. I want to finish here.
Very good, Mark. Thank you very much for a very comprehensive, great videos, great illustration. So I'd like to open up the floor for questions. We're running a little late, but I think we have time for a couple questions. Deepak, would you like to say something? You're muted, Deepak.
Can I? This is Muthukumar. Can I start the discussion?
Yeah, sure.
Okay. Manas, that was a great presentation, very informative as usual. I have a couple of quick questions. One is that regarding the aqueductoplasty, and I've done a few aqueductoplasties recently, but I always have a doubt how far, what's the length of the Fogarty catheter which you insert? Do you measure it in the preoperative CT scan or the MRI scan? How far do you insert the Fogarty? And you did say that you should not dilate the Fogarty more than 2 to 3 millimeters, which most of us do. But is there any guideline as to how far, what the length of the Fogarty? Because if you do not insert it to the entire length of the aqueduct, you are going to only partially dilate the aqueduct. And traditionally, aqueductoplasty works only for short segment stenosis. So, what's your opinion on that?
Means normally we identify the level of the stenosis from the ostium of the aqueduct, from the third ventricle in the pre-op MR. And in the Fogarty, we calculate that what is the distance you have to insert to achieve that. So, before inserting the Fogarty catheter, we make a marking, but where to what the distance you have to push it in to achieve the perforating the stenosis as well as dilatation. Usually a mark on the Fogarty catheter with a marker pen. So that's easy to know how much you have gone in.
And do you take any special precaution regarding the cortical entry point for the endoscope? Because if the sheath entry point, there's a sizable corticotomy there, which leads to the formation of a subdural hygroma in some, especially in younger children. Do you adopt any special technique for that? Because when there is a corticotomy opening, in the presence of this is a low resistance path through which the CSF flows out and forms a subdural effusion. It not only forms a subdural effusion, the pressure gradient for the stoma to function also is lost.
Yeah, the opening on the pia is important in both to prevent subdural effusion as well as to prevent subdural hematomas also. If the opening is small, when one is inserting the endoscope, the brain gets pushed and you have remote tearing of the subdural vein, and that can cause subdural hematoma postoperatively. And if it's too big, then you can have subdural effusion as you explained. To prevent subdural effusion, earlier we used to have effusion, but nowadays what we do is we make it a point to plug the opening of the cortex. We take the pericranium of the where we make the flap and plug it with the pericranium. Or if the child is very thin, if you do not have adequate pericranium, if the skin is very thin, we have used Durafoam to plug the cortical plug so that the subdural effusion can be reduced. We usually plug the cortex.
Yeah. So, we usually cut the gel foam, which is dry, and roll it into a cigar form and plug it in so that it swells and occludes the opening. Since
but the gel foam still is like CSF still goes through that.
CSF does seep through that, but since we have started doing that, we have not had any subdural effusion. So apparently it does work.
Yeah, we put pericranium or Durafoam.
Okay.
Manas, excellent presentation, Manas. I wanted to ask you which are the thalamic tumors with hydrocephalus wherein you prefer to do endoscopic biopsies? Are there any specific subsets which make you decide I will not do stereotactic, I will rather go for endoscopic biopsy and ventriculostomy at the same time?
Yeah, if the thalamic tumor, you have three options. If you have a thalamic tumor, either you do a stereotactic biopsy or an open surgery or endoscopic biopsy. If the patient comes without hydrocephalus, we do either a stereotactic biopsy or open surgery. To decide whether biopsy or open surgery, we do a diffusion tractography (DTI), and if the fibers are infiltrated, we do a biopsy. Otherwise, we plan open surgery also. If the patient comes with hydrocephalus, then we do an endoscopic third ventriculostomy as well as biopsy. But many times the thalamic tumors can be very big, where you do not, the whole third ventricle is obliterated, where you cannot do a third ventriculostomy. In those cases, we do a biopsy, we do a septostomy, and put in a shunt also in the same sitting.
And one last question, with the recent availability of international infantile hydrocephalus study results, though the data is quite restricted, we got I think 158 cases and less than 30% of the patients were actually randomized. Still, the trial says the ETB success rate is approximately 60% at 3, 6 and 12 months. Now, what is the advice you give to the parents of a child who comes to you with a 3-month-old child with acute ductal stenosis and hydrocephalus? I'm sure a lot of us actually still prefer doing endoscopic third ventriculostomy rather than offering a shunt, even if the child is less than 6 months of age, because of the inherent risk of shunt-associated morbidity. What actually do you practice, and what advice do you give to the parents when the child is quite young with hydrocephalus and acute ductal stenosis?
Yeah, we have not published, but we have analyzed our studies where children, the hydrocephalus is due to acute ductal stenosis. 3 to 6 months, we advise third ventriculostomy. But then, if aqueduct we don't find a significant acute ductal stenosis and there is a communicant hydrocephalus, there is no acute ductal stenosis, we still do a shunt. But even if you do a third ventriculostomy in a child who is more than 3 months, we always warn them that the success rate is only 70 to 80%, and still you may have to go for a shunt. And if they agree for that, then we do a third ventriculostomy. Many parents, they don't want to go for a second surgery; they go for shunt directly. But some parents, they don't want a foreign body; they agree for a third ventriculostomy.
Thank you. Thank you, Manas. Thank you.
Okay, great. We're running a little late, so I'd like to wrap it up. Thank you, Manas, for a great talk, and we look forward to hearing more from you. And thank you for all the panel. So, Jimmy, let me just wrap it up before we start the next one. Thank you very much.
Thanks. Bye.
Okay, Manas, thank you. Okay, let me just introduce you. Hello, Dr. Chan.
Yes.
How you doing?
Can you hear me?
Okay, let me introduce you first formally, okay? I'm going to start the video separately from Manas's talk, okay? 10, 9, 8, 7, 6, 5, 4, 3. Good evening, this is Dr. John Bennett, broadcasting from Miami for Neurosurgical TV in collaboration with Deepak Gupta of the Department of Neurosurgery of the AIMS Hospital in New Delhi. Tonight we have the pleasure of having, Chandrasekhar Pujari, MD, a very experienced neurosurgeon. He's been all over the world training. I'd like to hear about that too. And we have some distinguished panelists. Let's go around and introduce the panel first. Okay, we'll start with you, Deepak.
Hello, good morning, Dr. Dev Pujari. Thank you very much for joining us at this platform. And Dr. Dev Pujari is a very accomplished neurosurgeon with a special interest in pediatric neurosurgery in India. He is the past president of International Society of Pediatric Neurosurgery and also the past president of Indian Society of Pediatric Neurosurgery. We welcome you, Dr. Dev Pujari, sir, and we look forward to your talk. Thank you very much for joining us.
Thanks, Deepak. Look forward to sharing some space with you.
Natarajan, could you introduce yourself, please? You're muted. You're muted. Natarajan, okay.
Am I seen? Should I?
Yes, could you introduce yourself, please?
Right. So, thanks, gentlemen. Very nice to see all of you on a Sunday morning. My task today has been to talk on the arachnoid cyst management, and we collected some data recently, and we'll review some literature as well, and talk about specifically the endoscopic management of these cysts. Uh, I am speaking from Bombay Hospital in Mumbai, and though I'm interested in pediatric neurosurgery, we have experience with pediatric as well as adults, as per the pattern of my practice.
Very good. Do you want to continue with your presentation, Dr. Chen?
So I'll go on the screen share.
Yes. Mm-hmm. Let's see if we can do it.
Are we on?
Yes, yes, we are. We're on the. It's a bunch of slides. Yeah, there we go. Perfect. Very good.
Right. So basically, I think Manas has covered the ETV very well, and some of those points will come into discussion when we discuss the efficacy of endoscopic fenestration in arachnoid cysts as well. So let's go. I think arachnoid cysts are very well known that they develop because of either loculation or non-development of communication with the whole subarachnoid space, and the most common site are of course Sylvian fissure, followed by chiasmatic and supracellular cisterns, interhemispheric fissure, cisterna magna, quadrigeminal prepontine cisterns, occasionally over cerebral convexity, and we are seeing more and more of intraventricular cysts. The earlier textbooks mentioned it to be a very rare abnormality. There have been some attempts of making anatomical classification, and the best known classification, which is dependent on communication with the subarachnoid space and size, is by Galassi, and this has been specially based on CT cysternography. I am not aware of a study done on MRCSF flow study, but basically we talk about communicating, non-communicating, and then according to the size we talk about stage 1, 2, 3. Many of them are usually symptomatic, and when they be asymptomatic, and when they become symptomatic, many children, especially in very young age, they can present with symptoms of hydrocephalus, like progressive head enlargement and occasionally headache in older children. Seizures could also be an important presentation, and focal neurological problems can be a presentation in some patients who are decompensated. So this is a typical example of an arachnoid cyst child who was diagnosed to have Sylvian arachnoid cyst at birth. Because of the slightly increased head, this MRI was done, and everything looks nice and lax, and there are no displacements, and it was decided to treat this child conservatively. But as the child grew, there was around 6 months of age, the child decompensated, the head circumference started increasing and became symptomatic with seizures and some amount of right hemiparesis at the age of 6 years. And at this stage, the child was treated. Now, what options we have for treatment? We could either consider craniotomy with removal of membranes and fenestration into ambience and supracellular cisterns, or we could use almost the same thing except for the removal of membrane, but manage to do a fenestration with either endoscope or microscope, or we could simply resort to cystoperitoneal shunt. There are some people who would do both the things simultaneously, or most people would do one treatment followed if necessary by the other treatment. And we have now several series which have talked about this, and what we see is that people have shown a very good result with cystoperitoneal shunt, more than 90% success rate in various series. Craniotomy and cyst excision also has a close to 90% success rate, but the percentage of patients requiring shunt seems to be a little higher, while endoscopic fenestration gives you about 70% success rate in this particular uh, series, or in fact, this is a collection of a few series meta-analysis, and about 30% patients have required shunt in this meta-analysis of 304 patients. There are obvious advantages to doing a microsurgical cyst excision, like that the whole cyst can be visualized, multiple fenestrations can be done, marsupialization is more effective, and if you want to do ECG monitoring, you could do it during that, and of course avoid long-term short-related complications. However, this is of course more time-consuming and more invasive technique, especially in very young children, and the brain handling uh, can create certain issues in terms of neurological deficits. Endoscopic fenestrations, which are becoming more and more popular, are of course minimally invasive, safe, and have been shown to be fairly effective. Comparatively less blood loss, which can be an important factor in very small children. It of course avoids the shunt-related complications, and multiloculated cysts can be more effectively treated because with different trajectories you could make openings in various directions and communicate all of them together, uh, even with endoscopy, which can be a difficult problem if you are putting in a shunt. On the other hand, it certainly requires a more trained personnel and equipment, and reformation of membrane has been considered an important consideration. This is specific to some locations, as we will come to it later on, and not it's very poorly understood why it should be so. So I think if we look at ventricular shunting, it certainly decreases raised ICP, and the problem then comes is, should we also be considering ventricular shunting? And this problem is much more acute in patients who have ventricular or paraventricular cysts. And I think this is another thing which we'll address as we go along. And of course, we have to worry about problems of delayed shunt infections, dependency occasionally, and need for revisions. So this is another patient. This patient has presented actually as an adult to us with continuous headaches. He is a high uh, demanding profession and high functioning individual, and he is bothered with headaches for the last 6 months or so, which have been increasing, and this is the scan he comes to us with. So how do we proceed further? So at the first instance, we have tried to we look him for other other parameters of raised intracranial pressure, and there is no papilledema, and there are no focal neurological deficits. So this patient has been advised to be observed closely for next 3 months, and then maybe repeat an MRI. And he comes back with a repeat MRI, which also shows that the shunt is undisturbed, but his headaches have not subsided at all. At this stage, we decided to do a mini craniotomy and endoscopic fenestration, and I would just show you how we do this. We do a small craniotomy slightly in forward, slightly in front of the cyst, because it is easier to close the opening, and then I am entering the cyst and trying to make fenestrations. We do not use an energy source so that especially the nerves are not injured. And in this kind of I'm using the monopolar diathermy probe only to sort of mechanically open it. And then to increase the fenestration, I am not using a Fogarty catheter because I do not want pressure to be exerted on the third nerve, which is fairly close. So the first fenestration has been made into the between the carotid artery and the third nerve, and we are entering now the interpeduncular cistern. You can see the nerves down there, and this is the opening. Once we are coming out of it, I have got the widening of the opening is achieved by scissors, as I told you, and also by inserting the scope itself, which causes further dilatation. Then I am making another one between the tentorium and the third nerve, and usually we end up making at least 3 fenestrations like this. One will be between the optic nerve and the carotid artery, And then very occasionally the Liliequist membrane might also have to be perforated. Let us see how we go here. So we do not see any further arachnoid membrane beyond that, and the third opening is now being done between the optic nerve and the carotid. And this one I am dilating the stoma. There is some space here to do that. And again, make sure that you do not have a second arachnoid membrane. Is it necessary to do all three fenestrations? I am not sure, but to get a very wide fenestration is difficult. You can probably cut it in a linear manner, but it is supposed to, that kind of a stoma is supposed to close. So this is the post-operative MRI. The patient was actually relieved of his headaches almost the day after the surgery and progressively improved. And we do usually an MRI follow-up after about 3 months. I will talk about other location cysts where we have some other policy, but in this we have done this MRI at 3 months. You can see the turbulent flow suggesting that and we usually check it up also with a MR cineflow cysternography, where you can see a communication between the cyst and the basal cisterns. This is the sagittal view of the same, and this patient has not had any further problem in about 9 years follow-up now. Another patient who's presented essentially with epilepsy, and here we again decided to do this case by doing a proper craniotomy because we wanted EKG recordings during the procedure, and the microscopic marsupialization has been done. Surprisingly, we could not record any EKG spikes either before or after, and we decided not to resect any part of the brain. And this patient has again remained seizure free almost now for about 8 years. What do we do if the patient is asymptomatic? I think observation, 6 monthly follow-up is usually done by most of us. The main argument against observation is that shorter the period of compression, more likely it is to recover. And this is argued by many people who feel that we should even treat asymptomatic patients if there has a mass effect. What some of the problems which we see if the arachnoid cyst is not treated, one of them is this. This is a teenage girl who was appearing for her exams, and in the middle of the exam she presented with sudden headaches. It is quite obvious that she has developed a subdural, and you will see that she also has sorry, I'm going back to this slide, and there was a hemorrhage into an arachnoid cyst, and this hemorrhage created quite a bit of disturbance, and she needed to have a drainage procedure. And at the same time, we were wondering what to do with the arachnoid cyst. Of course, with the presence of blood, making any fenestration does not make much of a sense. And 1 year later, you find that the cyst has reduced in size, and there is no subdural collection. So we are still observing this girl now about 4 years after the surgery and have not actually touched her arachnoid cyst. Another patient who has presented with a frank hemorrhage. First time around, this patient presented with hemorrhage as the first presentation, and she again required an emergency evacuation, and again we have not fenestrated the cyst because of the presence of blood, and you will find that 1 year later the cyst has remained the same. She is completely asymptomatic, no seizures at all, and the subdural collection of course has resolved completely. She has had further follow-up scans, and the cyst has not progressed further, and she has remained asymptomatic. So again, the question is, should we electively treat these arachnoid cysts after an episode of subdural hemorrhage? I think is still a controversial phenomenon. What do we do with the antenatal detection of a temporal arachnoid cyst? This is one of the antenatal consultations which we had for an arachnoid cyst in the temporal fossa. This is at the 6 months of gestation, and as there was no associated hydrocephalus and no other anomalies, we decided just to observe the child and keep a close follow-up. And this is the size of the cyst, as you can see. And this is about 6 days after birth when we did MRI of the infant. An MRI shows a fairly large cyst. However, there is no hydrocephalus, and this child is completely asymptomatic for raised ICP. The fontanelle is fairly soft, and we decided to wait and kept him on actually a monthly follow-up. And at 6 months, the child started showing bulging in the fontanelle, became cranky, and I think this is the time. 6 weeks, in fact, sorry. At 6 weeks, we had the child with bulging fontanelle, and we decided to go ahead and do a fenestration. So this was fenestrated endoscopically, and the child responded initially, but the head circumference kept on increasing, and we subsequently shunted the child at 6 months of age. Suprasellar arachnoid cysts present a different kind of a problem. Many of them present in teenage children, either with gelastic epilepsy or occasionally with raised intracranial pressure, and in younger age they present with raised intracranial pressure, older age they present mainly with gelastic epilepsy, and you will find that this third ventricular cyst is usually, the sella remains normal, and there is a functional aqueduct stenosis. So the best way to treat this cyst would be, before that I will just give a explanation of why I was talking about the sella being normal. There are another kind of cysts in this region which are actually predominantly sellar cysts, which can also develop into third ventricle, and these patients usually present with visual disturbance, hypopituitarism, and there is usually no hydrocephalus. So you need to differentiate between these two. And the best way to treat this is to do a frontal burr hole, and this is an endoscopic fenestration. I am using energy source. I am using unipolar diathermy to coagulate the cyst membrane, and then to enlarge this cyst as much as possible. Insert the endoscope inside to make sure that I do a double fenestration, and we would do a fenestration here into the interpeduncular cistern like a third ventriculostomy, and the results of two fenestrations or bilateral fenestrations, biportal is not the correct word, bilateral fenestrations on either side of the cyst to communicate into the cisternal component has over 92% success rate, while if you do only a only one wall fenestrations, the success rate is around 60%. And the main reason for this is the functional aqueductal stenosis after the cyst collapses might open up in some cases, but it may not open up in some cases. And actually there are some suggestions in literature that after you do the first fenestration, you can probably inject a dye, make sure aqueduct is patent or not, or see it by endoscopy itself, and then decide if you are going to do the second fenestration or not. But I routinely do fenestration in both the walls in all the patients, rather than depending on aqueduct patency. So this is the child. What you typically see is that the cyst just decompresses. It does not disappear, of course, but you can see the CSF flow sequences, the turbulence of CSF at the bottom of the third ventricle, the flow going through the stoma in the prepontine cistern. On the other hand, the cysts which are enlarging the pituitary fossa, presenting with visual symptoms, they are usually seen in older age group, and these patients are best treated by this is a endoscopic method, but a transnasal method. You can see the thinned out cellar floor, and this is the cyst which we have first punctured, and you typically see some kind of a ball wall mechanism, if you can see it over here, which has definitely caused this, and that is being closed with fat. We used a glue to do this, and then you close the sella in a proper manner so that you do not get leak, and this seems to
Excuse
have
me,
solved the
Doctor.
problem.
Okay.
Yes.
Okay, I can see it now. That's fine.
Okay.
That's fine.
So I was just trying to show the ball wall mechanism in the stoma. You know there is a small opening over here, and you could actually see it with every pulsation that the CSF is egress into the cyst. So we close this and then we plug the defect, and this is how this patient has been treated. These are post-operative CT scans. There has been definite improvement in the visual function. However, the hormonal function hardly ever shows improvement. These are not as common as the earlier shown supracellular cysts, which are more commonly seen in children. What do we do about intraventricular arachnoid cysts? And I think here endoscopy has really made life much easier, because to get into intraventricular cysts by an open surgery probably is too much of a maneuver and cannot be very effective, as you cannot enter all parts of the ventricle by one portal entry. The only problem with endoscopic cyst fenestration is that there is a toughness and vascularity of the arachnoid membrane, which can make it very difficult sometimes to enter the cyst membrane, or if there is a hemorrhage, then it can create a problem for you, and you should be prepared for that. So this is one typical patient. This patient presented at the age of about 6 months with enlarging ventricles, bulging fontanelle, and again double fenestration is important. So we have entered into this cyst, and once you enter into this cyst, make sure that you do not cause any hemorrhage. There are usually some vascular areas. You can test that area quite well with one of the instruments. Go inside the cyst, and then usually we will make a second fenestration also, so that the cyst has been opened at least in two different areas, and CSF flow is established in a much better way. And this is actually within 3 weeks that the cyst has collapsed substantially, with a mild subdural which cleared up later on. Another cyst, this is a patient who had a difficult birth history and presented to us with mild infection, and this patient was treated with antibiotic, and this was a small cyst which was seen at that time. This child comes back to us about 6 months later with enlarging head, and now you can see that the cyst has enlarged with some amount of hydrocephalus. This was again tackled with endoscopic fenestration from a frontal burr hole, and you can see that the cyst has resolved substantially, with also reduction in hydrocephalus, because that was causing the functional aqueductal opening. Larger quadrigeminal cistern arachnoid cysts can also be similarly treated. We usually do a third ventriculostomy as well as an opening into the quadrigeminal cistern cyst, and this is one such patient where there has been a reduction in this. However, this is one patient, I must say, who had probably the membrane reformed, the cyst reformed, and this patient required a second surgery before this problem was resolved. When you have cysts in other areas, you have to use innovative approaches. This is a patient with an interhemispheric cyst, and I think what we have done here is that we have entered into this cyst from the opposite ventricle in this manner. I think probably we will have a picture here. So this is the cyst, as you can see, in the coronal plane, and this is how we made a septostomy, and septostomy alone resolved the problem for a while. However, though there was no loculation, the ventricles remained large, and eventually this patient required a ventriculoperitoneal shunt. This is an adult patient who presented with raised intracranial pressure and dementia over a period of time. This is the kind of cyst this patient has presented with. So the dilemma was really, how are we going to approach this cyst? and I found that as the ventricles were not enlarged and we did not have a definite trajectory to enter the ventricle without disturbing substantial amount of brain tissue, we decided to do a small opening. So we did a small parasagittal craniotomy, entered the cyst, and fenestrated it into actually the interhemispheric cyst at the bottom between the two olfactory tracts. And at the end of 3 months, the patient comes back with a scan, substantial improvement in walking and dementia. The presentation was more like a normal pressure hydrocephalus in a 40-year-old person, and this has completely resolved with complete relief of the symptoms. So microscopic fenestration still has a substantial role to play, especially in cysts in such odd areas. This is another patient. We have been thinking how are we going to approach this, and I cannot find a cistern except for the surface cistern itself where I can open this. So I decided actually to do a marsupialization of this cyst and a microscopic marsupialization. This is immediately post-operatively. We kept this catheter for a short while to see if something was draining, and removed it after about I think 4 or 5 days. Posterior fossa cysts, I think, are still a problem. This is a child who has presented to us with the deformity of the fourth ventricle, as you can see, a cyst which is in the CP angle with some amount of hydrocephalus. And this cyst, we found it very difficult to find a place to fenestrate it substantially. And I think even today, one of the best ways probably to tackle such cysts is to make a small craniotomy and marsupialize this cyst, like this child was done, and the hydrocephalus has resolved after marsupialization of cyst at 3 months, and the cyst has substantially reduced with normalization of the anatomy of the fourth ventricle. So I think if you look at the literature, we have definite evidence that decompression of arachnoid cyst yields a substantial clinical benefit with a low risk of severe complications, which may partly answer that should we be treating asymptomatic cysts or not. But I think this decision in an adult is probably easier because the symptoms are more manifest and they would complain about it. In very small children, you may have to consider, if you find a very large cyst, that you may treat an asymptomatic patient. The other things which we look at by some authors who have concluded that surgical treatment of arachnoid cyst is overall good outcome, but most people practice microsurgical decompression, and this is true with most of the papers which came in 90s and early this century as well. And people still maintain that microsurgical fenestration, especially for arachnoid cyst, has provided superior results than just endoscopic fenestration. Macom's review in 96 have shown two important factors: that the success rate of fenestration among these patients with associated hydrocephalus was higher than those without hydrocephalus, was significantly higher than those with hydrocephalus. And the other thing which I showed is that in those patients with hydrocephalus, cyst fenestration with or without a ventriculoperitoneal shunt has been practiced, and they found that cyst fenestration with ventriculoperitoneal shunt helped these children in a much better manner. This is another paper from Europe which has shown that the patients with symptom related to intracranial hypertension, acute neurological deficit, and macrocrania has obviously the best operative outcome, and patients with the same side epilepsy syndrome also have a good outcome. Marsupialization represented the best surgical option in this series. Actually, this was a survey conducted by DeRocco and colleagues, and they found that there is the responses which they got from all over the world. That analysis showed that cyst marsupialization presented the best surgical option. Endoscopic cyst marsupialization is now considered, though it is practiced exclusively by about 28%. Many people feel that with a mini craniotomy, this may still be the best outcome. I would conclude by saying that though endoscopic fenestration, microscopic marsupialization, and ventriculoperitoneal shunt all have well-defined options in arachnoid cysts at many other locations, I think surgical options are not so clear in temporal arachnoid cysts. we can only say that surgery has a definite proved benefit, that endoscopic fenestration is the current flavor, and cystoperitoneal plus minus ventriculoperitoneal shunt is probably the first option when the patient has an associated hydrocephalus. Thank you for a patient history.
Thank you, Dr. Chan, for quality presentation. Okay, we'll open the panel up for questions. Okay, Deepak, do you have some comments or questions?
Thank you very much, Dr. Depujari. Excellent presentations. I don't have any questions. It's quite explicit.
Okay, thank you. How about you, Natararan? Do you have any questions or comments for Dr.
Depujari, there was an excellent presentation, and I just have only one question. When you started your presentation, there was the first case which you showed with the temporal arachnoids. You said you had done a mini craniotomy to do the fenestration. Can you tell me, elaborate why there is a need for a mini craniotomy rather than a simple burr hole in the
Absolutely. So, if you have a large temporal arachnoid cyst, earlier and even today in many cases, we try to do a mini craniotomy. I do this kind of a thing even for, when I treat below 1 year ETVs, I try to do a mini craniotomy because I can get a good dural closure. Apart from, the subdural effusions, one of the problems which we have faced is also actually CSF leakage from the wound. And I think that has been a major advantage by doing a mini craniotomy. Your dural closure is better. You can take a small flap and then go in. Later on, we have changed to making a burr hole adjacent so that you have some amount of brain matter before you enter the cyst. So these are the two options.
I thought the way you, this is really interesting because dural closure is, watertight dural closure in a small burr hole is really difficult. And my initial impression was that maybe by doing a mini craniotomy, you are able to get a better angulation of the scope so as to reach the different portions. Is it so, or that really does not matter?
No, at the base it really does not matter. I mean, yes, it might avoid two burr holes if you are doing a posterior third ventricular lesion. It might avoid you two burr holes because you get better angulation. But in temporal arachnoid cyst, that is not the reason. The main reason is the CSF leakage and better closure of the stoma.
Okay, very good. Okay, Dr. Chan, we'll wrap it up. And you can get off the screen share. Just click on the green arrow to get off it. And I'd just like to say, Dr. Chan, if you want to teach in your senior years, this is a great platform to do it. You can teach all of India from your home.
Thanks, John. I think this is my first experience, and it's really wonderful to see some friends and share some experience on a Sunday morning. Thank you.
You'll be able to continue to share your training and all your experience from your home, and I look forward to hopefully hearing you in the coming years. And thank you all.
The rest of the day.
Okay,
I just want to add, Dr. Depujari, it is just not for people who are watching you. This is being live telecast, and there will be lots and lots of people who will be watching you both online and subsequently offline on Neurosurgery TV. So whatever talk you have given will be seen by lots and lots of delegates, and you can subsequently see your talk, how many people have viewed your talk after 1 month, 1 year down the line. So this is a very, very important and a strong teaching tool, and I really thank you very much on behalf of this online conference group that you agreed and you spared your valuable time for this. Thank you very much, sir. Thank you.
No, thanks, Deepak, for this initiative, and thanks, John, for all the hard work. Thanks.
Okay, we'll be seeing you soon. And thank you, everyone. We're going to start with Dr. Cherian's in about 15 minutes. I'll send everyone a new link to come in. Thank you. We'll see you then.
Thanks.
And then